Hey, good morning. We can get started with the industry presentations. They already it's live on YouTube, so it's going to be recorded, and there are lots of people who are logged in who are watching it. So I think before we start the main thing, if the industry guys can come and briefly make a presentation, we can get started so that we can be on time then. So yeah, I think Medtronic guys there, yeah, why don't you come and get started with your, yeah? More people are on the way, but it's being recorded and it's live, so people can watch it later on also.
इसको रेप्लिकेट कर दो क्या बोलते हैं नेम चंद्रशेखर yeah. So good morning to all of you, and thanks for the opportunity, Dr. Raghuram sir, for giving this opportunity to present. So I'll be presenting on the Medtronic drug-coated balloon, but first I would like to talk about the Medtronic portfolio. We have got different self-expanding stent, balloon expandable for various indications like carotid, iliac, SFA, BTK, and AVF. And the most important among this portfolio is HawkOne and Impact Admiral, for which we have this meeting, the DCB. So just wanted to share this slide with you, how the therapy has evolved in the past 4 decades. And over the decades, we see that the patency has been improving with the introduction of new technology. So we see now the drug-coated balloon, which was launched in 2014 with a patency rate of almost like 88%. And then now we have data on the HawkOne and the DCB, which provides better outcomes than DCB alone. So if you are talking about Medtronic DCB, we have the Impact Admiral Extreme as a platform, which comes in diameter of 4 to 7 and in lengths of 40 to 250 millimeters. So this is the new addition, 200 and 250 mm. The drug is Paclitaxel, which is an anti-proliferative drug with a drug concentration of 3.5 microgram per millimeter square. The excipient is a urea, which is a naturally occurring substance in the body, so less of inflammatory response with this excipient. And the coating process is proprietary. We follow uniform drug coating process. So you can see here the drug is mixed with urea, and then the matrix is actually applied to the balloon in a semi-inflated state, so that there is minimal drug loss when you are delivering the drug, and the right dosage is delivered to the arterial wall. And majority of the matrix protected within the folds of the balloon. So when the matrix contacts blood, the blood hydrates urea, and urea actually pushes Paclitaxel into the tissue, and it penetrates deep into the media and stays there at therapeutic level for over like 180 days. And if you're talking about the trial, we have the Impact SFA trial, which was a study conducted with 331 patients, randomized to Impact, and the control arm, which is the PTA, 111 patients. The efficacy was, this is an efficacy trial, and the primary endpoint was 12-month primary patency and freedom from clinically driven TLR. So this is a result which we got, like 74.5% of the patient are freedom from TLR, from clinically driven TLR at the end of 5 years. And this is a progression, as you can see, from 1 to 5 years. Still, the DCB continues to perform better than the plain balloon arm, although the difference is not as significant as in the first few years. So all the industry have got the same drug, mostly Paclitaxel, but how do DCB differ from one to other is the drug concentration, the excipient, the coating technology, and the state of the drug, whether it is amorphous or solid crystalline state, the size matrix, clinical trial follow-up duration, and inclusion-exclusion criteria in the clinical trials. So in Medtronic, what we have is the solid phase drug, which remains in the tissue for a longer duration of time. And you can see here, the higher tissue drug levels is maintained through the 90 days, which actually inhibits the restenosis process and has given us these results. In terms of size matrix, we have from 4 to 7. lengths of 40 to 250 millimeter. And just talking about Hawk 1, this is a new introduction. Now it comes in 7.6 French also. So we had one trial, a reality trial, which is a combination of Hawk 1 and DCB. So you can see the patient complexity here. The lesion had bilateral calcium of PACS score of 3 and 4 in 86.2% of the patient. The diameter restenosis was almost like 88.8%. The average lesion length was long. It was like 18 centimeter with chronic total occlusion component of 39%. So in this, we have got a result like 92.6% freedom from clinically driven TLR with a bailout stent rate of only 8.8%, because if you are doing only DCB or any other studies have shown that the bailout stent rate is much higher. But if you are using a Hawk 1 and removing all the plaque, the bailout stent rate is much lower. So this is what we have. And then finally, I would like to sum up here saying that Impact Admiral has been studied in over 21 studies with more than 20 publications, and 3,500 patients have been studied with Impact Admiral. In all the studies, it has shown consistent result in the range of primary patency of 88% to 92% in Impact SFA, Impact China, Impact Japan, and Impact Global trial. So the data, if you want to remember, you can see that 3 out of 4 patients remain TLR free at the end of 5 years in this trial. And again, lastly, more than 375,000 patients have been treated worldwide. And it has been in the market for last 10 years. So this is the last slide. So DCB in general has proven to be safe and effective in treating simple to complex SFA lesion. And Impact Admiral has been in the market for last 10 years. And we have a lot of evidence which is unprecedented in breadth and quality. Thank you. Thanks.
So if there are no questions for the Medtronic people, then I think next, Abbott guys, are you there?
Is Boston around? Abbott, okay, yeah, come. It's okay, you can start.
So, good morning everyone. So I am Umesh. I will be representing the Abbott portfolio for the endovascular portfolio. So coming to our endovascular overview, so we have starting from right from the carotids, we have the emboscule protection device, which we call as emboscule NAV6, and we have two types of stents for the carotid portfolio. One is a closed cell design, which is exact, which comes in both cylindrical and a tapered one, and the other one which we have is Acculink, which is an open cell technology designed stent, particularly for the ICA and CCA stenting. And in this also we have both tapered as well as the straight stents available. Coming to our iliac and SFA portfolio, we have one of the renowned stent, that is Absolute Pro and Pro LL, which has got a very comfortable deliverability system, which is one of the best stent across for all the iliacs and SFA lesions. And for the vascular mimetic implants, we have the Supera, which is one of the finest stent interwoven technology. And coming to the balloon mounted stent, we have the Erculink, which is for renal cases. And we have the balloon expandable stent for the other iliacs and SFA or subclavian, so 6 French compatibility with the OmniLink Elite. And we have the complete range of the balloon portfolio right from the iliac to tibials, comprising of Armada 35, Armada 18 and Armada 14. And we have also have the 018 platform balloons are also available, and some renowned guide wires which we have for the workhorse and as well as the specialty guide wires also available. And coming to the last, we have recently launched our Stealth 360 device, which is the orbital atherectomy device. For the more information, you can visit our stall. I will be very happy to showcase our product. Thank you.
Thanks, Umesh. If no questions, we move to the next company, BD. Is BD around?
And thank you very much to the Vessomag team to given us an opportunity to present on the some of the BD product. So I will take just a minute on so to complete on the Lutonics, because there were few questions on the Rotarex, so we will take 2-3 minutes on the Rotarex, talking on the indication where you can use the product. Okay. So what we see the effective DCB formulation, so it is very important that it retain the drug till it is in the vessel. It ensure a rapid drug transfer once it is in the lesion, and have a uniform, durable and transfer efficient coating. So that is what we say as the effective DCB formulation. These are the available sizes in the Lutonics in 035. So 4 to 6 diameter, and the length wise it is a 40, 60, 80, 100, 120 and 150. Catheter length is 130 centimeter. And if you see that the 5 French sheath is enough to get this into the lesion and vessel. For 014 DCB, we have a diameter from 2 to 3.5, and there are two lengths are available. One is the 80 and one is the 120. 150 is the catheter shaft length. These are the few important points. I'm not going into the detail into the studies and all, but this is what is important when you use any DCB. Coating integrity, Lutonics 035 has a durable coating with just 0.08 percentage drug loss within the introducer sheet during the insertion. So that is the finding in the clinical trials. Coating uniformity, if you see that the 035 is uniformly coated while inflated, allowing for 360 paclitaxial coverage to the targeted vessel with the drug variability of the 4%. Superior primary patency that everyone knows here, that is 73.5% compared to the 56.8% with the Alone PTA, and freedom from the primary safety event within a 365 days is approx 87%. Freedom from total lesion revascularization is 90%. TLR comparison, if you see that the Lutonics 035 demonstrated as a TLR rate consistent with the SFS stent. We also have a geo-aligned marker, so I mean to reduce the fluoroscopic time by the facilitating repeated catheter alignment at the lesion without the fluoroscopy. So our argument is that the Lutonics is the one of the safest product. There are a lot of products available in the market which are very effective, but I think that the Lutonics is one of the product which is a very safest, and that's why it is available in both 035 and 014. This is to optimize the drug delivery. Transit time lesion should not be more than 30 seconds. It has to be deployed within 30 seconds. Balloon pressure should be around 7 atmospheric, and balloon inflammation time should be 120 seconds, and depending upon your practice, but that should be the minimum. Final residual stenosis is the less than 20%, that is what is the finding, and balloon sizing should be 1:1. We also said that the 5 mm on the both the side, distal and proximal, you should have the balloon, so have the optimized benefit of the DCB for Lutonics. So that's for the, I'm just also take you through the Rotarex. Just 1 minute. What is the excipient? Is the sorbitol. Sorbitol is, you know, it's very, so that's why the drug loss is a minimum, and it's like a sugar. So when it comes in a contact with the lesion vessel, I think it's absorbed very easily within the lesion. So because yesterday there were few questions, so I thought that just take on the Rotarex also. So this is the entire unit. You see that you have a drive system. There is a connector, And if you see, this is the in a separate box, the entire catheter set is comes. Then there is also a foot paddle. So suppose if you want to use a foot paddle and I mean with the hand, if you want to just use for the catheter insertion, you can use the foot paddle. It is the over the wire for 6 and 8. It has to be a 0.18 wire which comes along with the kit. So that is about this setup. I think it's okay. So here is the difference. This is the Rotarex. So the orange part, whatever you see, that's rotate. That is the head. And if you see, there are the helix along the catheter. And because of that helix, when it rotate at the speed of, for 1 minute, it is a 60,000 rotation. And because of that rotation, that otex gets formed. And because of that otex, that the once thrombus get fragmented, it gets aspirated, and then you can collect into the bag which is the outside. So these are the Rotarex sizes: 6 French, 8 French and 10 French. Vessel diameter is from 3 to 12 mm, not less or not more than 12 mm we should do it. Usable lengths are with the 6 is 110, 135. With 8 French it's 85, 110, and with 10 French is the 85 centimeter. So that's about the Rotarex, and the same sizes are available even in the Aspirex. So here, these are the what the indication and the range of the application for the Rotarex. From 3 to 12 mm artery stent and grafts you can use it. Acute, subacute and chronic for the artery I am saying, you can use this product. But when it comes to a vein, it should be used only, mostly it is in the acute, or if it's a less than 40 days thrombus, you can use the Aspirex. But in the arteries, you can even use in the chronic. The, huh? 14 days, 14 days. And that's why we are also saying, because it works on the rotation, it does not have any kind of the blade, it will not useful in the calcified lesion. So we always saying that please avoid, and that's why whenever you want to use a Rotarex, we always request you to please first you do some kind of the CTA angio, or at least see that how old is the thrombus, or maybe you can discuss with our application expert Tej. So he has a set of the lot of I mean they have a lot of cases where they can see that whether it can be used in that particular. And even if you think that the everything is a fine, but at the time if the wire is not crossing, I think because it's over the wire we cannot use. Otherwise, it's very easy to use. Many times, doctor says that how to find that the thrombus is very old or the new. I think maybe we can take out some thrombus, aspirate some of the thrombus with the color of the thrombus. We can know if the guide wire is passing very easily through the lesion. I think we can use a Rotarex or the Aspirex without any issue. So this is the Aspirex. So in the Aspirex, there is a no head which is moving. So in the Rotarex, there is a fragmentation of the thrombus, then it aspirate. Here it first aspirate, and because of the otex form, because of the rotation, it gets fragmented, and then it gets out of the, and you can then collect it in the collecting bag. So that's the difference between the Rotarex and the Aspirex. These are the same sizes, okay. So these are the limits: subintimal position of the guide wire, impossibility to pass the lesion completely with the guide wire. So guide wire is very important. Undersize or oversize vessel diameter, and the heavy calcification. These are the area where you cannot, I mean that's the limitation of Rotarex. Thank you so much. I think this is the only platform we find that you have given an opportunity to industry to talk about their product. Thank you so much. Thanks, Vessomag. Thank you.
If no questions, we move on to the next company. Is Relicis here? Okay. Boston? Yeah, please come on.
Yeah. So good morning to everyone. I'm Aditya from Boston Scientific. I look after Mumbai. First of all, I would like to thank Vessomag entire body for giving this opportunity to be part of such a great platform. Uh, first of all, today I'm very excited to discuss about Boston Scientific, the commitment towards addressing restenosis and improving outcomes for the patients across worldwide. With the decades of experience and innovation in the drug-eluting technologies, we are leading this fight and we are quite proud about it. When it comes to the Boston Scientific expertise, our journey is built on solid foundations. It's been more than 6 millions of the patients where the implants have already done. It's been more than 20 years. We started our journey with paclitaxel. The expertise enables us to advance the fight against the peripheral arterial disease effectively, offering the patients and clinician more confidence to select the device also. Restenosis rates and comparison when it comes, which is essential and very critical situations for any kind of patient. So to provide such a better solution, I think even if you look at the data pointer also, approximately 38% there is a chances of restenosis with the bare metal stents. However, PTA there is almost 45% of percentage of the restenosis rate. However, Boston Scientific is trying to give a better solution in terms of giving drug-eluting technologies, which will give a better results and reduce the leading problems. In our industry, patients are the end users, and for them using any kind of product, evidence does matters, and that's why we are also proud of it. We feel proud of it that our technology are the most rigorous and study in the market in the field, and backed by the different kinds of RCTs as well as real world studies and clinical trials. Almost 10,000 implants has been done, as we have already discussed, and I'm sure we will keep this fight again going forward, and will provide a good solution so going forward. So even we look at the, when it comes to the drug-eluting technologies, we have mainly two products, that is Eluvia, which is a drug-eluting stent, and another one is a Ranger, which is drug-eluting balloon. Apart from that, we have recently launched a atherectomy device, which is a rotational atherectomy called the Jetstream. And for more information, I would like to invite you to please visit Boston Scientific booth as well as the website for more information. Thank you.
If no questions, we'll move on to Concept Medical.
Hi, good morning everyone. I'm Vijay Sharma. I'm a group product manager with Concept Medical. Uh, so, Concept Medical is the first company in the world which has researched, developed and patented the sirolimus coated balloon, not only in coronary artery disease but also in the peripheral artery disease. And we have more than 35 plus patents, 100 plus patents for different technologies, and 5 US FDA IDE for our different Magic Touch drug-coated balloons. So this is our journey from 2008 till 2018. We have the company is incepted in the year 2008, and then by 2018 we had the complete range of drug-coated balloons for coronary artery disease and peripheral artery disease, as well as drug-eluting stents for coronary artery disease. In our product portfolio, we have DCB family, PTCA balloons, drug-eluting stents, and PTA balloons. In our DCB family, we have Magic Touch SCB for the coronary interventions, Magic Touch PTA for peripheral interventions, Magic Touch AVF for AV fistula, and Magic Touch ED for erectile dysfunction. All the products are CE approved. And now with the first three products, Magic Touch SCB, PTA, and AVF, we have initiated our US FDA trials. We have already got 5 IDE approvals for these three products to do our trials in the US. So Magic Touch is based on a robust clinical data with 4,000 plus patients clinical data. We have 2 US FDA ID approvals in SFA and BTK, and we have 12 clinical studies ongoing on our peripheral artery on Magic Touch PTA as well as on Magic Touch AVF and ED. Why DCB? Because there was a prevalence of versus stents in PAD, because there was a prevalence of stent fractures, and the 5-year data of target lesion revascularization shows that both are very high, were very high for above the knee procedures. There was a permanent metallic cage which leads to further complications, no approach to popliteal and below the knee procedures, and longer the metal cage increases the revascularization. And the recommended guidelines for DCB in ISR and short femoropopliteal FemPep lesions is class B treatment. So these are some of the clinical evidences where now the DCBs were developed over the treatment of DES in the treatment of peripheral artery disease. Why sirolimus? That also is a very big question when we started researching about putting a coating a sirolimus on the surface of the balloon. Sirolimus was, by that time, sirolimus has proven their efficacy and safety in coronary artery disease as well as in peripheral artery disease to be coated on the surface of the stents as a proliferative agent for, and it also has the therapeutic advantage over the other drug available to be coated on the surface of the stents and the balloons. And being sirolimus, it's a cytostatic drug and it has 10,000 fold safety margin comparing paclitaxel. So this is only drug versus drug, paclitaxel versus sirolimus. They are both similar but different because both of them are anti-restenotic, but one of them is cytostatic, another one is cytotoxic. Sirolimus has proven their safety margin of 10,000 fold in multiple trials, whereas it has low absorption and low retention. So that these were the two reasons why the sirolimus was not coated on the surface of the balloon. And we are the first one to find out how to coat it on the surface of the balloon and how to improve absorption and the retention. Maximum doses of paclitaxel as per the IFUs of different paclitaxel coated balloons is 14,200 microgram, and the longest size paclitaxel balloon contains 9,000 microgram. So it means not more than one for the longest size can be used for one procedure as per IFUs, as per the US FDA guidelines. And as per the US FDA guidelines, they have to mention, paclitaxel coated balloons have to mention the maximum dose on their balloons in their IFUs for the safety of the patient. So what were the challenges with sirolimus coated balloon? The challenge was to coat the sirolimus on the surface of the balloon, and the other challenge was it has a shorter tissue retention. Therefore, technology was needed to improve that, and also there was a technology needed to improve the low absorption of sirolimus from the surface of the balloon. So Concept Medical is the world's first company to found out that way with the patented nanolute technology. And then with that technology, we developed our Magic Touch balloons, whether it is coronary balloon, peripheral balloon, or AVF. To coat sirolimus drug on the surface of the balloon to improve the tissue retention. This is our technology. Nanolute is a patented technology in the world by Concept Medical. What we are using a phospholipid. So phospholipid is a carrier which encapsulates the sirolimus submicron and which improves the lipophilicity of the drug. Once it is encapsulated, it is being sprayed circumferentially on the surface of the balloon so that the drug is available equally on the surface of the balloon. And this is how we do it. We reduce the size of sirolimus into submicron size, then encapsulate with the phospholipid. Once it is encapsulated, it improves absorption and retention both. So once it is developed upon inflation, the nanocarriers releases a drug from the surface of balloon to intima, and then it migrates from intima to media and ultimately to adventitia, where it stores as a reservoir, and from there it is available for its action at the stenotic lesion. We are the first one which has a widest range of the PTA balloons, Magic Touch PTA, available for compatibility with all three 014, 018 and 035 for the treatment of SFA and BTK. Even we have the longer shaft so that it can reach the areas where the other catheters are not able to reach to treat the stenosis, especially in the cases of tibial arteries, peroneal arteries, and dorsalis PTS. So what this Magic Touch PTA provides a clinical benefit. It provides immediate drug release in the vessel wall, drug penetration to the deepest layer of the vessel with low distal embolization, and avoids no flow and slow flow. No foreign object left behind in the vessel. Yesterday there was a discussion on the size of the molecule of, especially in the paclitaxel. One study is being shown where the Luteinix, Impact and Ranger agents, distal embolization sizes were shown. In the case of sirolimus, there are no such distal embolization. There are animal studies being done where it has proven better than agent and the other POBA technology. So the other benefit that it has proven efficacy in higher patency rate and proven efficacy in the lesions where the Rutherford score is 5 and 6 and Wi-Fi score of 4 and 5, which is proven. Dr. Edward Choke definitely will speak about this EXTOSI and HOPE registries. Both the registries have shown efficacy and safety of Magic Touch PTA in peripheral artery disease. This is the range we have with the smaller size of 2 and the larger size up to 12, and the compatibility with 014, 035 and 018 shafts. So with Magic Touch, we have these FDA approvals, not FDA, IDE, not approvals. This IDE is investigation device exemption to initiate trials in the US. And we have already started our trials on Magic Touch PTA in SFA and BTK, for AVF in treatment of stenotic lesions in arteriovenous fistula, and in SCB, ISR and small vessels. So this is one of the DTF study to prove that because initial allegations on us was that there was no drug and sirolimus cannot be coated on a surface of a balloon, and it cannot migrate from the balloon to the different layers of the vessel. So this study is being done to prove the fact that there is a drug on the surface of the balloon, and the drug migrates, travels from the balloon to intima, and intima to media, and then ultimately to adventitia in the first 7 days. This study is only done to prove the fact that it migrates, and it is available in the adventitia as a reservoir for the duration of up to 45 to 60 days, but the maximum availability of drug is up to 120 days in the arterial walls for this. So we have these are the trials which are ongoing. There are 12 trials: EXTOSI, Beyond EXTOSI, HOPE, Debate, BTK, Future SFA, SERPAD. Sirona is recently presented in 1 year outcomes of Sirona recently presented in TCT. AMATSA, Spain, LIMES, BTK, IDE, FE, FDA, and SFA. So these, with this clinical backup and the type of evidences we are will be presenting in the coming months or the years, we are quite confident that Magic Touch PTA, Magic Touch AVF, and ED will definitely find a place in your practice. Thank you so much for giving us an opportunity to present our technology. On behalf of Concept Medical, I thank everyone, and thank you so much.
Will one question?
So the technology-wise is same. There is no difference between the technology as well as the coating. Only the sizes are different.
So are there sizes in AVF which are not available in PTA?
Yes, sir. PTA has all the sizes, but in AVF there are less sizes.
You just branded it separately, but it's the same thing.
Yes. Technology is same, sir. Because technology is same, sir. Yeah.
We go to the next session, Advanced Applications and Emerging Technologies. I would request Dr. Shehzad Bulzara, Dr. Harshvardhan Oak, and Dr. Pranjal Melge to kindly come and take the front seat. The first speaker for us will be joining us on Zoom, Dr. Edward Chok, who will talk about paclitaxel versus sirolimus, unpacking the debate.
Hi. Hi, everyone. Can you hear me?
We can hear you.
Great. Could you enable my screen sharing, please? At the moment, I can't share my screen.
Sir, just 1 minute more. They're just,
Sure.
yeah, we can see you.
Great. Hi.
If you could just share your screen, sir. Can you
Sure.
do that?
It says that the host has disabled my screen sharing.
You can try it now, sir.
Okay, great. Thank you. Right. We okay to start?
Yes, sir.
Right. Hi. Good afternoon, everyone. Thank you very much. Thank you very much for inviting me to give this talk, paclitaxel versus sirolimus. My name is Edward Chok. I'm a vascular surgeon at Northern Heart Hospital, Penang, and before that, I was in Singapore. So we'll go straight into it. There are two choices for drug-coated balloons in the market for treating peripheral arterial disease at the moment: paclitaxel-coated balloon and sirolimus-coated balloon. Now, obviously, paclitaxel-coated balloon has been around longer, so I'm going to go into the data surrounding both these drug-coated balloons. And when we talk about drug-coated balloons, we need to talk about above the knee and also below the knee separately. And for me, we need to consider the efficacy versus the safety of these drug-coated balloons. So let's move on to talk about paclitaxel-coated balloons for above the knee. Now, this has been around for a long time now. And so we know that in terms of efficacy, there is no doubt that paclitaxel-coated balloon is superior to POBA. However, in 2018, safety concerns were raised, and this was quite controversial. And since then, there have been new data to demonstrate no safety concerns with paclitaxel-coated balloons. So there are multiple level 1 evidence for PCBs for above the knee SFA. All these are randomized, multi-center, blinded, core lab controlled, and CRO controlled trials which have shown that paclitaxel-coated balloon is superior to POBA for above the knee. And this is the summary of some of the major RCTs. The Lutonix RCT showed superior 1-year primary patency for paclitaxel-coated balloon, and so did the Ranger SFA and the Impact SFA studies as well. So then, why do we need alternatives to paclitaxel if paclitaxel is so superior? One of the first concerns was published in 2018 by the Katsanos meta-analysis, which showed that at 2 years, there was, according to their data, a 68% relative risk increase of all-cause death. And at 5 years, the numbers were even worse with a 93% relative risk increases. This has, as you know, caused quite a lot of controversy at the time, and since then, multiple other investigators have also shown through their other RCTs that this was in fact not their experience with the use of paclitaxel-coated balloon. This was one of the trials called the SWEET-VAS trial published in New England Journal of Medicine, which showed that there was no increase in mortality with paclitaxel-coated devices. And similarly, when the German investigators looked at their own healthcare, they looked at all their 9.2 million insured people, and they showed that neither DCB or drug-eluting stents with paclitaxel was associated with any increased long-term mortality. What about paclitaxel for BTK? This, for me, is the greater concern with the use of paclitaxel-coated balloons. As you know, there are multiple challenges with below the knee arteries. These are very challenging arteries. These are small, frequently calcified with long CTOs, and there is a real risk of thrombosis with distal embolization leading to acute limb ischemia. All of these will lead to poorer patency with high rates of recurrent disease and high rates of reintervention in general for below the knee arteries. So let's look at the data available for paclitaxel-coated balloon and below the knee. Now, I think it would be fair for all of us to say that for paclitaxel-coated balloon, they are very good for above the knee, but for BTK, they have shown equivocal results. And in fact, it is also high concerns with amputation rates with paclitaxel-coated balloons when these are used for CLTR patients in below the knee. So there have been multiple negative paclitaxel-coated balloon trials for BTK, and some of these are Impact Deep and the Singapacli trial. The Singapacli is our own trial for Singapore. The Impact Deep trial was one of the earliest trials on the use of paclitaxel-coated balloons for BTK. This was a large trial of about 358 patients, 2-to-1 randomization of 239 paclitaxel versus 119 POBA. Follow-up was with 5 years. This was using the Medtronic Impact Amphiron paclitaxel-coated balloon. And this was the key 12 months efficacy endpoint, and they showed that there was actually no difference in efficacy endpoint between paclitaxel and POBA for BTK. Now, what is more worrying from this trial is that they showed that amputation rates at 12 months was higher if you use paclitaxel-coated balloons. 20 in the paclitaxel-coated balloon group versus 4. And this resulted in Medtronic recalling the use of their Impact Amphiron paclitaxel-coated balloon for below-the-knee disease based on these trial results. This was our own trial, Singapacli trial, which was published quite recently. A smaller trial, 138 patients, 1-to-1 randomization of paclitaxel versus POBA using the Biotronic Pasio 18 Lux paclitaxel-coated balloon. And this was the key results. At 6 months, primary patency was no difference between the paclitaxel-coated balloon group versus the POBA group, and amputation at 12 months was also statistically no difference, but numerically was worse in the paclitaxel-coated balloon group. So this resulted in us not using any paclitaxel-coated balloon in our BTK arteries in Singapore. And Casanos also went on to publish a meta-analysis looking at the risk of major amputation following application of paclitaxel-coated balloons for CRTI patients. And they concluded from this meta-analysis of about 21 RCTs involving nearly 4,000 lower limbs that the risk of major amputation was significantly higher for paclitaxel-coated balloons. Some trials did show positive paclitaxel-coated balloon results for BTK, and this was the Debate BTK and ECOAT-2 BTK. The Lutonix BTK also said that this was a positive trial according to the authors, but for some reason, the FDA did not approve the use of Lutonix for BTK in the US. And we'll go on to look at why that was so. So this is the Debate BTK. It was a 1-to-1 randomization of about 132 patients, and they showed that 12 months binary restenosis was superior in the paclitaxel-coated balloon group compared to POBA. And there was also significantly better freedom from TLR in the PCB group. The ECOAT-2 trial was a trial from China, and it showed that for BTK arteries, the use of their PCB also resulted in a superior result compared to POBA. 6 months primary patency was 75% compared to only 28% in the control group, and CTTLR was also better. The Lutonix group was a large trial of about 462 patients looking at composite primary effectiveness endpoint assessed at 12 months, which they define as freedom from major amputation, target vessel occlusion, and also CDTLR. And they reported that there was a 10.5% improvement over POBA when you use their paclitaxel-coated balloons in their primary effectiveness endpoint. So for all intents and purposes, they tried to report this as a positive trial. However, when this was looked at by the US FDA, this was unanimously voted against allowing the use of Lutonix paclitaxel-coated balloons for BTK in the US. So if you look at the timeline, the study was launched in 2013. However, they implemented statistical and endpoint changes in 2016. This was submitted to FDA, this was not approved, and they resubmitted to FDA, and again, this was not approved. I guess the main thing was that the FDA did not like the changes to the protocol. The primary effectiveness endpoint, for example, was changed from 12 months to 6 months. They added proximal segment as a co-primary endpoint, and they increased the sample size, and they adjusted for interim analysis. So I think for SFA, if you want to use PCBs, I would say that efficacy of paclitaxel in firm pop lesions is proven. There may be issues with mortality for claudicants according to the meta-analysis. However, this has been largely disproven. For BTK, what about the use of PCBs? The use of PCBs is less proven. It is equivocal, and there are lessons to be learned from the impact Ampheron PCB. With the newer generation PCBs, there may be some use, but I would still say be careful. And in our own experience in the Singapore trial, we would definitely avoid the use of paclitaxel-coated balloon, particularly in our calcified BTK arteries. So I'd like to now go on to update you on the landscape of the use of sirolimus-coated balloons for both above the knee and below the knee. There are currently 2 sirolimus-coated balloons available in the market. You can use the Magic Touch, which I use a lot, and you can also use the solution SLR from Cordis. Other companies are also coming out with their own sirolimus-coated balloons, Symodics and also BD with the Prevision sirolimus-coated balloons, but these are much more early, and they haven't got their own regulatory approval for use in the market. So why do I think sirolimus is the better drug compared to paclitaxel? The cardiologists have known this for a long time. This is a meta-analysis of the use of sirolimus devices for coronary artery disease published in JAMA more than 20 years ago. And in this meta-analysis, they showed that the use of sirolimus results in better angiographic restenosis rate, better target lesion revascularization rates in a population of nearly 4,000 patients. What are the biological plausibility for the advantages of sirolimus over paclitaxel? Now, you've heard about earlier on in the earlier talk about all the advantages, and I'm going to go through this again. Now, sirolimus, we know that can also inhibit SMC migration much more effectively than paclitaxel. And we know that SMC are the main causes of neointimal hyperplasia. Secondly, in addition, sirolimus also has anti-inflammatory properties. So I think this potentially can explain why sirolimus-coated balloons could be of much more benefit in below the knee arteries. And lastly, it has got no pro-apoptotic effects. It is cytostatic, and it is not cytotoxic compared to paclitaxel. So what is the evidence for sirolimus-coated balloon trials for SFA? So I'll go through SFA evidence first, and these are the first in-human single-arm trials. The one in green, we've already got the results available. The one in yellow are the larger trials, which are still ongoing. And I'm pleased to say that I was the principal investigator for the Magic Touch trial, and we investigated the use of Magic Touch for SFA in the EXOC trial, and the results are available, and I'm going to go through this. So this was the earlier trial published by the German group looking at the solution first in human trial. And I want to focus your attention to the leftmost column, which is a sirolimus-coated balloon trial. And they looked at 6-month late lumen loss. The lower the late lumen loss, the better it is. And they were able to show that using this solution for SFA, the 6 months late lumen loss was very low for solution. This was 0.19 millimeters compared to 1.04 for POBA. And also compared to other trials using the paclitaxel-coated balloons for SFA, the 6 months late lumen loss for solution using the sirolimus-coated balloon was the best. In our own experience in the EXOC first-in-human trial, we showed that there was promising 6 months primary patency in the femoral popliteal segment. The 6 months primary patency was 88%. So how does this compare to our experience using paclitaxel-coated balloon? So you can see that the results are comparable. The sirolimus-coated balloon was 88% 6 months primary patency, and when we compare that to other data from the paclitaxel-coated balloon, namely the Ranger SFA and the Levant 2 trial, the 6 months primary patency for using sirolimus-coated balloon is almost the same as that using paclitaxel-coated balloons. So what about randomized controlled trial data for sirolimus-coated balloon? And I'm pleased to say that there is one trial using the Magic Touch called the Sirona trial, which was just recently made available only about 3 months ago. And this was the Sirona trial. The investigators in this trial recruited about 478 patients, and this was a head-to-head trial of sirolimus-coated balloon using Magic Touch versus paclitaxel. And they reported that in this world's first head-to-head comparison of sirolimus versus paclitaxel in fem-pop artery, that the primary patency of sirolimus drug-coated balloon was non-inferior to that of paclitaxel, 73.8% versus 75%. And in terms of CDTLR as well, there was no significant difference between sirolimus-coated balloon and paclitaxel-coated balloon. So what about sirolimus-coated balloon for below-the-knee arteries? And for me, this is the area of most interest because in Asia, we treat mostly CLTI and BTK arteries. And so far, for BTK, the results are quite poor with just POBA alone. And we know that for PCB, this is not the solution because, first of all, there's no benefit. And secondly, we're concerned about the high amputation rates. So what do we know so far about sirolimus-coated balloon for BTK? It's fair to say that we just have early data from small single-arm registries at the moment. These have shown promising results. I think it is better than POBA. However, there is not any RCT data available yet. So from our own EXOC trial, we published that the 6 months primary patency for below the knee was 74%. And this we felt very excited about because we know that we can only achieve much less primary patency using just POBA alone. In addition, there was also low requirements for repeated interventions at 12 months. TLR was high at 86%. Freedom from TLR was high at 86%. And we showed excellent 12 months limb salvage success at 92%. So how did the sirolimus compare to paclitaxel-coated balloon? We know from our single paclitaxel trial that you can only achieve 40% 6 months primary patency with paclitaxel-coated balloon, compared to a much better 74% in sirolimus-coated balloon. So for me, this was the most exciting part of the trial. And this was one of the patients from the trial, and this is she underwent the use of sirolimus-coated balloon for the proximal anterior tibial artery. At 6 months, achieved successful wound healing, and we scanned her again. At 6 months, the proximal anterior tibial artery, which had been treated, remained clean. At 12 months, there was some hemodynamically non-significant lesions. We consider this as patent. At 24 months, again, patent proximal anterior tibial artery, and I followed this patient up to 4 years, and even at 4 years, you can see that the proximal anterior tibial artery remained patent. We've also got real-world data because we've used a lot of sirolimus-coated balloon in our own institution. We looked at patients enrolled between 2018 and 2021, and we looked at 3-year clinical outcomes. We've got a total of 141 patients with Magic Touch sirolimus-coated balloon, and we compared that to patients who received only POBA. In 206 patients, we looked at freedom from TLR, freedom from amputation, amputation-free survival, and overall survival. And I'd like to draw your attention particularly to the 3-year freedom from TLR when we looked at SCB compared to POBA alone. And for us, the use of the Magic Touch sirolimus-coated balloon has profoundly impacted our practice in that you can see from here, the freedom from TLR, if you use sirolimus-coated balloon, was much more superior compared to the use of POBA alone. We can see that the graphs start to diverge at about the 6 months point because we feel that at this point, the sirolimus-coated balloon was able to act against neo-intimal hyperplasia, which usually starts to occur at about the 6 months period. And in terms of survival, there was also improved survival in our patients who received the sirolimus-coated balloon, 64% versus 55%, and we believe this is due to the frequently less target lesion revascularization in very high-risk population. So what are the ongoing SCB randomized control trials for BTK? There are multiple of these happening around the world at the moment. None of these are completed yet. However, I'm pleased to say that the largest one of this, Surprat, has already completed their enrollment. So the results from this should be available in about 12 months' time. And I suspect that hopefully this will show a positive outcome for sirolimus-coated balloon, and then we can start using sirolimus-coated balloon for our BTK arteries. I'd like to draw your attention to the fact that sirolimus-coated balloon using Magic Touch BTK, even when applied to very distal arteries and the plantar arch, shows no distal embolization or slow flow phenomenon in my experience. This is one of the patients who had severe BTK arteries, and you can see how I applied POBA and applied this Magic Touch sirolimus-coated balloon all the way down to the plantar arch, and there was no slow flow phenomenon after application of the Magic Touch. In terms of the vascular community, you can see that already 2 years ago, 54%, the majority in Charing Cross poll agreed that sirolimus is a better drug compared to paclitaxel. And when the poll was reconducted in 2023, again, the majority agreed that sirolimus is the answer to CLTI. So I'd like to just conclude by saying that for SFA, we know that paclitaxel is very effective. However, we've got very recent data to show that SCB is just as effective to PCB according to the Sirona trial. For BTK, PCB is equivocal and may even be harmful. SCB has shown promising data from single-arm studies. There is no distal embolization from the use of SCB for distal arteries, but we now await RCT data to confirm if SCB is superior to POBA. Thank you very much for your attention.
Thank you very much, sir. Any questions? I think there are no questions, sir. Thanks a lot for your presentation. Hope to meet you again.
Thank you.
So we are preponing the next Zoom connection as well. This is to invite Dr. Venkatesh Ramaiah, who will be speaking on concept of biodegradable drug-coated scaffolds. He's joining us all the way from the US. Good morning, sir. Can you hear us? Dr. Venki Ramaiah, sir, you have to activate the video and audio both.
Okay, you should be able to.
Yes, sir, we can hear you and see you.
Very good.
Can you share your presentation, sir?
Yes, I am. Who am I speaking to?
I am Dr. Aniruddha, sir.
Oh, yeah. Oh, great. Anirudh, very good. Okay, I'm going to share my screen. Is it allowing me to share?
You are a co-host, sir. You can share.
Can you see it?
No, sir.
No?
Yes, we can see now.
No, can you see it? How about now?
Yes, sir, we can. This is the last slide.
End of the presentation. Okay, am I up or there's still time?
You can start, sir.
Are you ready to start? Who is there? Yes, we all are listening. The whole team is here. Everybody?
Everyone is here.
Oops, sorry. Hang on 1 minute. Okay, let's start now. Okay, guys, thank you so much. I want to congratulate, Dr. Shekhar and the entire team in Bombay for actually introducing this national symposium on drug elution. I think it's one of a kind, and I want to congratulate all of you for talking about something that is very, very dear to the future of critical limb ischemia and limb salvage. So my topic for today is basically to delve into the concept of biodegradable drug-coated scaffolds. And if you look at the history of revascularization, not only of the lower extremities, but also of the coronaries, you will realize that obviously balloon angioplasty has been the gold standard for a very, very long time. And then, of course, stents came in. And then, of course, drug elution and drug-eluting stents came in. And of course, there are problems still. We still don't have the absolute right answer to maintain patency of any revascularization. TOBA obviously is compromised by re-narrowing due to elastic recoil, acute closure, dissection, remodeling, and neointimal hyperplasia. The second revolution was obviously bare metal stents, but there is still a very high incidence of in-stent restenosis. And now we have drug-eluting stents, basically the Zilver as well as the Eluvia stent. But these stents still leave permanent metal implants inside the vessel with potential future problems such as fractures and others. So where is the goal for improvement? And the ideal design is to create a bioabsorbable stent design. It should have mechanical properties that will support the vessel and keep it open during that required period. It must be biocompatible. It should have adequate degradation and disappear without creating any intense inflammatory response. And obviously, it has to have good deliverability and should be able to carry on an anti-proliferative drug in order to reduce restenosis. So these are the advantages of bioabsorbable stents. What they potentially do is they delay endothelialization, they decrease the chronic inflammatory response and the localized hypersensitivity reaction. They return the vessel to probable normal vasomotion and prevent late luminal enlargement, expansive remodeling. And in addition to that, these advantages of bioabsorbable stents decrease the problem of jailing the ostium of branched vessels, as we see with metallic struts sticking into the vessel. So the scaffold is basically a polymeric stent, which is made of polyl lactic acid, PGA, or even PDLA, PCL. These are basically long chains that get hydrolyzed and basically eliminate via the Krebs cycle, which we used to study in medical school for a long time. And the degradation of polymeric stents vary between 6 to 24 months. The other scaffold is metallic stents, and these are basically magnesium alloys. They have very low elastic recoil, and the degradation ranges from 60 to 90 days, with the overall integrity for almost 28 days. So this is the scaffold. These are the kinds of scaffold. And obviously you can put different drugs on it, including everolimus or even sirolimus. In the United States, we have the Abbott Esprit BTK system that is FDA approved. I think it was approved in April of 24 last year. And I've had the opportunity of being one of the first to deploy this stent, especially in Arizona and our institution. And we've done probably about 10 cases so far. You got to remember, these stents are still extremely short and extremely narrow in diameter. And so you have to pick and choose your patients very carefully, in addition to the cost of these stents too. And that's our first stent that we put in. So let's look at why we are looking at these technologies, because the impact of critical limb ischemia is extremely well known. There are almost 150,000 amputations, but I'm not saying that these drug-eluting or drug biodegradable, bioabsorbable stents will completely decrease the levels of amputation, but it's another tool in your armamentarium to maintain patency and hopefully do further limb salvage and decrease amputations. But this is not the only way. You also have to survey these patients. You also have to do bypasses. You have to do reinterventions and follow these patients very closely. Critical limb ischemia, obviously, is almost the second cause of death after lung cancer. And there's a huge amount of expense, almost $12 billion attributed to critical limb ischemia. Annual cost per patient is about $35,000 in the United States. So if you revascularize these patients, there's definite improved survival. The amputation rate, quality of life definitely increases. And you can see with endovascular revascularization, the amputation rate has actually gone down to about 6.5% too. The problem with below knee revascularization is we do not have any technology, even bare metal stents. We've been using sometimes bailout off-label coronary stents in case of a persistent dissection, or even a covered stent in case you rupture or tear off a calcified anterior tibial vessel. And even drug-coated balloons have not given us very good results. And coronary metallic DES has limitations in below knee disease also. And the adoption of these stents in the legs is only very small. It's only about 5%. In fact, there was a trial called the PADDY trial that used coronary stents, paclitaxel eluting coronary stent systems. And the 5-year results were not too bad. I mean, it was almost, patency was not too bad at all. So what is the ideal way to maintain below knee vessels and keep them patent so that limb salvage rates can be very high? Bare metal stents, drug-eluting stents, atherectomy, lithotripsy, angioplasty, and drug-coated balloons are what we have now for BTK treatment. But to effectively treat BTK, I think what we've got to do is we got to do a vessel prep, whether it be balloon angioplasty or atherectomy, and then the concept of the ideal treatment is obviously a bioabsorbable, degradable, drug-coated stent. Long-term outcomes were done with reabsorbable scaffolds in patients with BTK device. The ADSORB BTK trial showed a 72.3% primary patency, and freedom from CDTLR was almost 90.7% with patient survival of greater than 50. So the term now is basically drug-eluting reabsorbable scaffold, DRS. It's not DES, it's not bioabsorbable stent. The term is basically DRS, drug-eluting reabsorbable scaffolds. And the new therapy addressing these three objectives are basically you have drug elution. Obviously, you can use everolimus or you can use sirolimus. Reabsorbable, because the scaffold has to get slowly reabsorbed, and then it provides sufficient support to prevent recoil, and then it slowly elutes. So the Esprit BTK system is the one that's FDA approved. It's basically, the scaffold is of course lactic PLA. It's reabsorbable scaffold. It definitely has less recoil, and it provides a platform of sustained drug delivery, and the drug is everolimus. And the scaffold, as you mentioned, nothing is left behind, and therefore the vessel then goes back to its original, hopefully, structure that is originally dealt with before. So if you look at the about 4 years of treatment of this BTK system, you will see that the metallic framework or the scaffold disappears within 24 months to 36 months. Generally at about 36 months, I think the whole scaffold is more or less gone through completely, and it reabsorbs completely, so that at 40 months, 48 months, or even 4 years, you'll see that the vessel left behind is almost like a primary native vessel. The scaffold is made of PLLA, and the scaffold contains PDLLA or lactic lactide that adheres to the scaffold. And obviously the drug is very thin layer, 2 to 4 microns thick, and has controlled drug release. So this is the stent that we have right now in the United States. The data is extremely promising. If you were part of the study, and the scaffold gets fully reabsorbed, as you mentioned, in about 36 months or so. And you can clearly see when the scaffold begins to dissolve, it is basically converted to water and carbon dioxide via the Krebs cycle. So let's look at the data. We were part of the live BTK study. There were about 261 patients randomized. The patients who had the BTK stent were about 173. This was a 2-to-1 randomization. And these patients were followed, and you can see this article was published in the New England Journal of Medicine too. And as you go forward, you'll see most of the inclusion criteria. As you can see, the patient had a vessel diameter of 2.5 to 4, and the CLI patients basically were Rutherford 4 and 5. And there were multiple sites involved, 50 of them, and the patients were randomized into a 2:1 randomization. And more or less, in terms of the characteristics and the target lesions, they were more or less comparable, AT, peroneal, and of course TPT and the PT. The stent diameters, available diameters are 2.5 to 3.5, and the lengths are up to 38 millimeters. And if you look at primary patency and limb salvage and freedom from major adverse events, you will see that the patency has been extremely good. If you look at primary efficacy endpoint, you see with the BTK stent 74.5% compared to plain balloon angioplasty. So there's an absolute risk difference of 30.8% with the Esprit BTK versus just plain balloon angioplasty. And this was pretty remarkable in terms of its original data, in the sense that we normally use long, slow, prolonged ballooning for below-knee vessels, and this has given us a much better patency rates compared to what we used to do with balloon angioplasty. So obviously this is a very low reintervention rate of only 6.5% in 1 year, and it's a very durable treatment, especially for patients with critical limb ischemia. There are consistently higher observed rates of limb salvage and primary patency across a range of lesions. And that's all of the data that's here. If you look at primary efficacy endpoint, you will see not only the short, medium, and long lesions, and you can see that the BTK Esprit stent is far superior compared to plain balloon angioplasty. And this continues for a period of almost a year with 92.6% patency rates. So how do you use this stent? I think you have to prep the lesion. You cross the lesion, you either do balloon angioplasty or you basically do an atherectomy, whether you use CSI or whether you use any other atherectomy device, or even plain simple balloon angioplasty, create a good luminal gain, and then basically deploy the stent, the sizes of which are very important. The first few cases I did with the help of IVIS, because these lesions, these vessels are fairly small, and sometimes you really need to size these vessels, not just eyeball and guess, basically. If you look at the availability of these stents, the smallest diameter is 2.5, and the largest diameter is 3.75. In terms of length, the smallest is 9 millimeters, and the longest is about 38 millimeters. So these are relatively short stents, and sometimes you got to use two. Also keep in mind the cost of these devices too. It's very simple. There's nothing difficult about this. You got to make sure that there are good radiopaque markers that you visualize, and if you have to put two, there should be at least a 1 millimeter of the stent overlap completely. You've got to achieve full expansion and do not leave the scaffold underexpanded. And therefore, the first few ones, if you do with IVIS pre and post, I think you'll get really good results and good apposition. Multiple scaffolds, you've got to have at least a 1 millimeter overlap of these patients too. Now, in terms of reimbursement, this is what we do in the United States, and you can see these patients can be done in the inpatient or in the hospital outpatient or in the OBL too. And so you got to keep into account the cost effectiveness of these methods of treatment. And most of the time, I've used these patients for single vessel runoffs that keep on going down. And so you got to be careful as to the exact number of stents and the cost effectiveness of the treatment too. Now, that's one of the stents that's FDA approved, but there are a couple of stents, in fact, that we are also involved in trials. The Riva Medical Motive BTK technology, I won't go into full details, but this is also ongoing. This is the one that we are going to be starting and enrolling very soon, the R3 vascular program, the magnitude bioabsorbable scaffold. We are just been approved for the site to visit, and we'll probably start enrolling these patients in the so-called elite BTK trial. This is another very impressive technology. It's called the ephemeral. I don't know whether the study has already started, but this has got multiple short drug-eluting balloon expandable reabsorbable elements. And it's mounted in a single delivery system and is deployed by balloon inflation. So the spacing allows for good motion of the treated peripheral artery so that there's not much manipulation in terms of movements of the thigh or the leg. And I think this one is also sirolimus compared to the other BTK stent that's available. And there have been trials done already, as you can see over here, in animal models, along with OCT and IVIS, and I think the data has been extremely good, and the US trial will be starting very quickly. Then there's the Champion-NIR study, stent also, and you can see this also is not completely available as yet. It's more in the coronaries. It is also a sirolimus drug that's involved in this. So the future of scaffolds will be designed as drug delivery technologies. And both of these, whether it be the metallic scaffolds or the others, are equally capable of drug delivery. And I think they're here to stay. But the question, of course, is going to be the cost, the length of these lesions, and whether they can be then put into the SFA and maybe even into the larger vessels. So larger scaffolds, longer scaffolds are definitely challenging for the rest of the vessels that we treat in the intrainguinal revascularization. So I'll present a quick case. So this patient was a 76-year-old. He had a thrombosed popliteal artery aneurysm and basically was in danger of losing his leg because he came with very critical limb ischemia. Multiple attempts at lytic treatment and endovascular interventions and revascularizations were done at the outside institution, and then he was transferred here. So at that time, he underwent a vein bypass to the anterior tibial. We had to literally hook it up to the anterior tibial and then go through the bypass to open up the single vessel anterior tibial. And we were able to salvage his leg, and he was doing fairly well for about a month. He went to Portland, Oregon for some wedding, and then he came back with severe critical limb ischemia and rest pain. And you'll see this is his bypass which we did, which is a vein bypass to the anterior tibial, and you can see there's this short segment. So this is probably one of the ideal cases for a below-knee DRS stent. If you look at his revascularization when we first did it, there was an area of dissection, you can see in the mid to distal anterior tibial, but that we had cleaned out nicely, ballooned it, and we didn't want to put any stents at that time, and we left him alone. And we felt that maybe it was that dissected area that was completely occluded. And that's where we put the we put the Esprit stent, and you can see he's got a huge anterior tibial that is completely revascularized with this particular stent. We did balloon it. We did do, I think we hocked it with an S device, and we did, and then we created a good vessel prep, and then we stented it because of persistent slow flow sort of a dissection. And the guy is still patent now, more than a long time too. So I think bioreabsorbable stents have the advantages of metallic stents, but also have drug-coated and of drug-coated balloons. They offer vessel support, they limit neointimal hyperplasia and late lumen loss over time. Eventually, this scaffold disappears and allows for return of the physiological vasomotion of the vessel. And I think these kinds of technologies are here to stay. The only issue is how large, how long, and what is the cost going to be. But I think this technology is here to stay. So in conclusion, I think bioabsorbable scaffolds, which were really started in the 1990s, are now finally coming into the market. And I think length, size, and cost are going to be very critical in determining their success. Thank you so much, guys, for this opportunity, and congratulations again on drug.
Thank you, Venkat. It's Rahul here.
Hello, Rahul, how are you?
I'm fine. A very interesting talk. I think absolutely agree with you. And this is the technology what we require in the infrapopliteal area. My question is, you know, when you do the clinical practice in India, like most of the disease is diabetic based.
Yeah.
And hardly get to have such patients who has got such a short lesions where you put in the scaffolds, you know, not more than 5%, I will say. Most of the lesions, we hardly use 120 millimeter balloons. Most of the time you have to use 150 or 200. So, you know, once you do the ballooning, you put in the stents only where, you know, either there is a flow limiting dissections or you're not able to get through it. You know, similar case what you showed. But most of the lesions, how do you put in, where to put in the device, this device? Because the uses in the clinical practice will be so little at present, you know, it will be limited to not more than 5% in my clinical practice. That's, I think, what this study shows is definitely it's better than the plain balloon. But when you will extrapolate this to the clinical scenarios, I think the uses will be much lesser.
I agree. I totally agree with you. And therefore, we are, even though it was approved in April, we've done about 8 to 10 cases. And so we have to pick and choose your cases. And you're absolutely right. I mean, the treatment of below knee disease is basically slow, long, prolonged, balloons, balloon angioplasty. And if you really have to put bioabsorbable DRS stents, I mean, these are just 3.8 centimeters long, 38 millimeters, and you'll be ending up putting 4, 5, 6 of them. And so the use and the adoption has been extremely slow in the United States. And if you look at all of the data, the lesion lengths are small and very, very focal lesions. And these need not even be treated sometimes with stents. There may be just balloon angioplasty or even atherectomy and balloon angioplasty. So yes, the adoption is going to be extremely slow. There is an immediate need for long stented segments, maybe even 6 to 10 centimeters long, at least. For below knee disease. And of course, sometimes you may have to treat 2 vessels or even, more or less to get adequate blood flow to that particular area of the heel or the toe. So you're right, absolutely right. Not only in India, even in the United States, I mean, the below knee disease is generally very calcific, especially in the diabetic renal failure patients. It's extremely long segment, diffuse disease. And therefore, it becomes extremely difficult to pick and choose your patients and adopt this technology. And it took us a long time to actually find good patients to get to use this technology. So there has to be a rapid improvement in terms of length and diameter of these. And I think if I had to use these, I think I would more or less focus on the SFA and make them larger and longer, because the SFAs, we still really do not have a good answer to those. Of course, below knee is also a challenge, but I think the longer diameter, larger stents have to be done. Otherwise, the adoption is going to be extremely slow. Plus, the cost also prevents it from being used, sort of superficially or just, just because if it was a cheaper one, yeah, you put it. And I'm actually surprised because in the United States, we do not even have a dedicated regular stent below the knee that is FDA approved, and we went straight away to a DRS or bioabsorbable degradable stent. And so that's another avenue to look at as to why this superseded almost a regular stent for below knee disease, which could be long segment stent. So right now, unless it's a single vessel focal disease that I can actually treat, I mean, we do have a few patients who have a single vessel runoff, even with the bypass. And I think those are the kinds of patients that this technology will be really helpful for. Below knee, diffuse disease, critical limb ischemia, I still use long segment balloons. I do use atherectomy. And then, of course, recently we've been using the serenator or the cutting balloon too. So it's not that we are randomly using these expensive technologies. I think there's a very small niche of patients right now who will determine whether this technology is ideal for them or not.
Hi, this is Shekhar here. Thanks for your very interesting presentation. Two observations I wanted to clarify from you. One, the Esprit, is this a rapid exchange rather than an OTW, right?
Yes, it's rapid exchange.
So why is it that, what is the basic technical thing in manufacturing? Why is it that these BTKs, as vascular surgeons, we struggle a bit with the rapid exchange as opposed to the OTW. So what is the funda behind making these small devices rapid exchange rather than OTW?
I think they copied the coronary technology, you see, because most of these biodegradable regulating stents were in the coronaries, and so they just extended that platform. It's not that difficult, Shekhar. Come on, you can use rapid exchange carotid stents all the time. So eventually, and also I think trackability is another question, because you go up and over all the way down to the pedal vessels. I think trackability is another issue. And so I think they stuck to the platform of coronary stenting, and eventually whether they do become over-the-wire technology will remain to be seen.
The other thing is, what is the, why have they chosen everolimus over the conventional paclitaxel and sirolimus while manufacturing this? Do you have an idea about, could you throw some light on that?
I think they're longer lasting, and paclitaxel, most of the balloons are paclitaxel coated balloons. So I think the technology or the use of paclitaxel and the long-term patency was not as good as everolimus, and now even sirolimus is coming. And I think paclitaxel will slowly and quickly be taken off. And I think these two, the sirolimus or the everolimus, will be the drugs of choice, especially as the drug can sit better into these platforms for drug delivery in these bioabsorbable platforms. Paclitaxel, you see when you use your drug-eluting balloons, you got to make sure the drug doesn't come off, you don't touch it, you don't irrigate it, you don't wet it. So I think paclitaxel may not, plus the paclitaxel may embolize too, as you saw in some of the data. So I think paclitaxel will not be the drug of choice for these biodegradable scaffolds.
Venkatesh Dhanesh here. Nice talk.
Oh, how are you, man? I hear a lot about Pune.
Yeah, they couldn't hear you in Chembur though today's talk. Okay, we did a similar kind of study with Merrill many years ago, about 5-6 years ago, and it was a very short study, and that time results were encouraging. The similar kind of platform with like Abbott. My question is, did you have any occasion where you had to do a re-angio after using DRS, and what was the kind of status on angiography, or did you have to go in surgically? Any occasions?
Not yet, but I'm sure we'll get, it may be also what I'm thinking is that area that you treat with the biodegradables platform may remain open, but before and after that, I think you'll see a lot of disease progression. So that is the other thing of using, short segments like this and short stents, which will cause further evaluation of the proximal and distal ends of the lesion. So far, like I said, we've done 8 or 10. And of course, the period is only not even 6 months since we started in April, May, June. Yeah. So far, we have not seen any reocclusions, restenosis, or reinterventions.
And did you have to use it? Have you used it in distal third of tibials? Maybe very short length occlusions?
No, most of these have been in the mid-tibials. Mid-tibials, nothing below the ankle for now.
Dr. Venkatesh, Dr. Shahzad here. 2 quick questions. One is the technical one. So it's a balloon mounted or a self-X stent, and the other
Balloon
was...
mounted.
Okay, and the other was, I know the stents are short, but the study that you showed, there were 3 divisions of the lengths, and at all the 3 levels of the lengths, the data showed that there was a good revascularization. So I'm just guessing the number of stents were put all across the lesions, or they were the angioplasty and just critical parts were stented?
Oh, no. I think a couple of those, if you look at the length of the lesions that were treated, all of them had either 1 or 2. So the length of the lesion was equivalent to the length of the stent used. So there were actually at least 2 stents used, if not 3 here. Let me just go back to that.
It was the largest one was like up to 148 millimeters. So that was a little like the 80 average 80 millimeter treated.
Yes. I think that was like three stents were used in that one, because the longest stent is a 38 millimeter stent. And so you're right. So that's what I'm saying is, if they don't make it longer, to put 3 of these at a rate of almost $3,500 is a little too much. And so here it is, I think. Let me see. Lesion, here it is.
Yes, this one.
So you're right. Yeah, 82 millimeters. 82 millimeters. And that's exactly 3 stents with the 1 millimeter overlap. So 369, and so 1 millimeter, so overlap. So 38, 38, 38. That is 3 stents exactly. And if you look at the 15, but the patencies are still not as good as if you do just 1 stent. So I think only time will tell. Obviously, in studies, you'll do short focal just to get the technology approved. But I think eventually in the real world, you will see a lot more diffuse lesions like you all talked about. And the practice pattern will definitely change, and cost will become a factor. And therefore, the adoption has been still very slow with the S-split stent.
Thank you. Thank you, Venki sir, for a very delightful talk. We'll move on to the next topic.
Thank you so much. Have fun. Take care.
Thank you, sir. We'll have a case presentation now, orbital atherectomy with sirolimus by Dr. R. Shekhar, sir.
Yeah. So, good morning, friends. So, after 2 overseas talks, I'll just quickly go through one of the cases representative of what we are discussing over the last 2 days. There was this 69-year-old male from Tanzania who had a large painful wound in the leg for 4 months. He was a hypertensive old CV stroke with a motor of 2/5 in the right leg. He was wheelchair bound most of the time, poorly controlled diabetes. And the relevant local examination, I'll just tell you just about what is locally found. There's a large 20/10 wound anteromedially and the lateral aspect of the distal leg. There's a lot of slough and tenderness with signs of ischemia. The distal pulses, meaning the dorsalis pedis, ATA, PTA, were not palpable. And this was what the wound looked like. You can see large thing almost surrounding the entire lower part of the leg, the medial lateral aspect as well as the ankle. So because there was a large wound here, we said probably a duplex will be challenging. Most of these cases when we send down for a duplex, they say the patient is in bandages and so technically not possible. So we said probably a CT is a better option, and if you see the CT, you'll realize that probably this is a severe BTK disease in the right leg, the affected leg. We did an angio, and this is what you can see on the angio. Just below the knee joint, there is a high-grade stenosis, and what you can see is a single vessel disease, the peroneal. Yeah, next is not playing. Is the video playing? No. Video is not playing. Yeah, does it play? No, it's not. It's not playing. Anyway. Right, but let's see if this plays. This doesn't play as well. Dear. Huh? Yeah, play it, yeah. Does it play? It's not playing, it's not connected, the player is not here. Anyway, so I'll, rather than waste time on this, I'll just quickly go to the slideshow and come to the core thing. So basically what we found in this was that when we did the angio, we found that the AT and PTA were forming just above the ankles as from the branches of the peroneal anterior and posterior branch. So typically as a surgeon we feel that ideally this would be a bypass where we take a piece of vein, reverse it and bypass it to the ATA PTA. But unfortunately there is a large area of slough and the wound had almost circumscribed, it was circumscribing the ankle, and so there was no area where we could actually plumb the vein into. And moreover, the quality of the GSV was not that great. So, what we did was, we said probably we'll do a POBA first. So we did a POBA with a 3.5 millimeter balloon, but it was non-yielding due to circumferential calcium. You can see there's still a residual lesion there. And so what we used was a Stealth 360. Now this probably would be the ideal lesion where you have a single vessel unable to do a bypass in a no stent zone, and so we use this, and let's hope this plays. Does this? Yeah. I think yeah. So I think this is playing. So basically this is just a demo to show you exactly what the, the Stealth 360 does. You have ideally this is meant for short segment calcified lesions. I find those are the best cases where you can use an atherectomy because the muck that goes down is minimized. And as you can see, this diamond back actually, it oscillates 360 degrees and literally like a sandpaper shaves off the whole plaque. So this is a brief video just to show you what actually it does. So what they say is that the particles that come out are very, very small, so you really don't need a filter. I'm not too sure about it, but basically why I prefer it only for the short segment, short segment lesions, so I don't particularly anticipate too much of muck. So that was our, and I don't know, many of you might not have used it, but when you use it, it's actually like a, it makes a sound of an aircraft actually landing, it's that loud. So you can actually get the feel of something being shaved inside. So that's the video of that. And as I said, the technology is designed to, it's a diamond coated head which basically sandpapers everything off. And following this, we use the Magic Touch sirolimus coated balloon, and that was what we got. I'll show you in the next picture. If you take a zoom of it, this is what it looked like. If you magnify, say, we got a fairly decent luminal gain with a post-atherectomy and a sirolimus coated balloon. Thereafter, we took the patient up for a debridement and then initially a dermal substitute, and we had a good wound healing. And end of the story is that basically he had a healed wound, came back, he went back home, and as we discussed yesterday also, the patency, I'm not really bothered about the patency, whether it is there or not. The fact is that he came with a large wound which has healed, which we have managed to heal, and that's a non-functional leg in the sense he is wheelchair bound. So his main primary issue was that he had a painful large wound, and any which way we've got it to heal. Thank you.
Any questions? We'll move on to the...
Yeah? Sorry? What we found from that, from the initial angio was that, I prefer IVL when it's a dense circumferential calcium. But in this case, we found there was, a scattered kind of calcium. It was predominantly atheromatous. And when we did the POBA, there was a recoil, but we presumed that it is probably a combination of the lesion and the calcium. Probably if it was a dense, one of those, I prefer to use IVL in cases where, you have a dense circumferential calcium. This wasn't the case in this.
There's also that coronary balloon, which is a completely NC balloon, which tolerates pressure of 30.
Well, this was a single runoff, so I was scared to put in too much. In fact, after the atherectomy, I didn't do a POBA. I straight away used a DCB, because that being the sole supply to the leg, I was scared that, if overdo it.
I can ask you a question till then, Rahul. Shekhar, did you try to open the ATA because you could see the nipple there and proximal third?
No, we just couldn't get anything into it. It was a rock.
Yeah. Please always never, just think one way of doing an endo. And these patients in, like my unit, very routinely we make them prone and do a localized endarterectomies and do a patch. They work very well. So we have done more than 40 cases up to now. localized popliteal thromboendarterectomy. It works magic. And the rate of success is very, very high because this area, popliteal artery, especially behind the knee, crossing is sometimes difficult. Very, very calcified lesions, as you know. And this is the one area where if you put in a stents, they don't last very long. So sometimes when there is a single vessel runoff, very, very bad 7-10 centimeter.
If you go through my slides, I specifically mentioned this is a no stent zone for me. For me, it's a no stent zone.
Yeah.
Two, as a surgeon, when I saw the distal runoff near the ankle, the first thing strikes me is I plumb a vein there, but it's got a circumferential infected wound there. So
No,
that
you can't
part
do the bypass.
was off.
Yeah.
This guy is very ill.
I know.
He's had a stroke. He
Yeah.
had a poor cardiac function, and he's generally
No, Shikhar,
not in good shape.
This is the best approach for this patient.
Yeah,
I'm
so-
just putting in a point that if the patient is fit, just one should also keep, let's say this runs down, let's say this does not run for a very long time and does not have a scaffold, bioscaffold, so it closes up again. So then we should always not say that we can't do anything about it. So please, just keeping the mind open, popliteal thrombectomy really works very well.
True, but as you said, we should think ahead also, not just end of the story. So for me, if this guy has if it closes down and he becomes symptomatic, we probably have a healed wound now, and now I'll probably do a bypass. Get arm vein or something and do a bypass.
I'm still saying again, I will not do the bypass again because if the wound is healed, and even if it's a small wound, comparatively, doing a bypass is like a major surgery if the patient is so sick. I will still do a localized popliteal thrombectomy and make only one vessel runoff. Because if the wound has healed up with only one vessel runoff with a peroneal into AT and PTA, then you don't require
if there's a one
bypass.
vessel runoff and the wound is healed, it's very unlikely that he's going to come back or have symptoms because he's wheelchair bound. And he's not using that leg. It's just the wound.
So one small question, sir. Great result, I saw your case. Which dermal substitute do you prefer in these kind of cases? Just one small comment on that.
See, if it's an infected, we use the Novosorb, which is a urean, it's a synthetic one, which is acceptable when there is a low-grade infection. If there's no infection, then Matridum is what we use. In this case, there's slough, so we use the Novosorb. Yeah.
Thank you very much, sir. We move on to the next set of chairpersons, Dr. Sumant Raj, Dr. Praveen Narkhede, and Dr. Piyush Jain. Please come ahead on the first 3 seats. And Dr. Ambarish Sathwik, sir, will be speaking on drug elution beyond the SFA, evidence of DEBs and BTK lesions.
Good morning. My immense gratitude to Vessomag for this invitation and for conceiving and executing this symposium. I'm fairly certain most of you are sleep deprived. Our rooms were strategically located under a nightclub last night, and youngsters were dancing away with the kind of energy that only they can summon. But I assure you my presentation with all the laden evidence is going to serve as a remedy for your sleep deprivation and put you to sleep. So it's a fairly dry topic, but let's see what we can do with this. what's the evidence for DCBs in the below the knee segment? And let's begin with an axiomatic self-evident truth, which is that you can't have CLTI without infragenicular or tibiopedal involvement. And the pattern, therefore, of atherosclerosis that we're concerned with is the kind that leads to CLTI, which looks like something like this. And so we're dealing with diabetic patients, elderly, with numerous other comorbidities, so it's a bad set to have. And in these kind of patients, what exactly is the kind of tibiopedal disease that you're dealing with? Remember, diabetics, heart disease, CKD, and so on. What kind of disease are you seeing in this common cohort of CLTI? You are seeing all occlusions, long ones, and usually in more than one tibials. The other thing to remember is that CLTI may be a terminal event. This is another truism that we must remember, and if best CLI data can show us something, it is that even if it isn't a terminal event, these patients are going to be dreadful risks. So this is the third truism that I wish to emphasize, and this is something we strongly believe in, which is that the management of CLTI is not about long-term patency. What you need is perfusion for roughly 200 days for wound healing and limb salvage. And this is encompassed by this wonderful phrase which is called situational perfusion enhancement, which means that if you have a wound, the oxygen demand of that wound is very high. Once it heals, even if the artery that you've opened up goes down, it returns to its baseline oxygen demand and usually doesn't recur. So we start this presentation with a fundamental question, which is that can POBA below the knee give you that situational perfusion enhancement? This is a systematic review and meta-analysis, 52 studies, roughly 6,800 patients. This is by Jihad Mustafa, and it showed that the pooled one-year patency after plain old balloon angioplasty was about 60 to 70%. And the one-year limb salvage rate was roughly about 85 to 86%. So you're safely crossing over that 200-day perfusion limit if you're doing a plain old balloon angioplasty. This is what matters. This is what you start with. And in this meta-analysis, the reintervention rates were about 18%. The other thing to remember is that even if you do manage to open up these below the knee segment vessels, in many instances, your best interventions may not salvage the limbs, and that's because of the scourge of small arterial disease. And recognition of small arterial disease has established a completely new scenario for CLTI. And it's now believed that MAC, or medial arterial calcinosis, is a reproducible and a powerful predictor of small arterial disease. It's easy to predict what the outcome is going to be just with an X-ray of the foot and a MAC score. What the MAC score is outside the purview of this presentation, but remember that. I mean, that's an information to be parked somewhere in the head. So SAD and MAC scores are very powerful predictors of the fate of CLTI patients. Part of SAD is an incomplete pedal arch. The pedal arch describes the connection between the anterior and the posterior circulation of the foot. And this very elegant 2017 paper from Florence brilliantly illustrates that it's the pedal arch patency and not direct angiosome revascularization that predicts the outcomes in CLTI, particularly in diabetics. So even the GVG guidelines now will ask you to factor in the status of the pedal arch. Completeness of the arch has a direct association with wound healing and limb salvage. Now, the reason I'm giving you such a long spiel and such a long prefatory exposition on this in a symposium on DCBs is because none of the trials involving DCBs in PTK lesions acknowledge this, any of what I just said, or factor in any of these complexities. Now, I wasn't there, unfortunately, for Dr. Devendra's presentation yesterday, but the history of drug-eluting technologies, particularly below the knee, counterintuitively starts off with drug-eluting stents. So drug-eluting stents came first, and they were largely limus-based, not largely, entirely limus-based, and then drug-coated balloon technology happens later. You would think that DCBs come first and DES comes later, but it happens in the reverse way. Drug-eluting stents come first, and our learning from drug-eluting stents was as follows, and in animal studies, that vascular smooth muscle cells start to hyperproliferate within 24 hours. So you need a large dose of the drug to immediately be conveyed to the artery. And what you need is a sustained drug for 30, 60, possibly even 90 days. And this is critical because this is the duration during which restenosis is going to have the highest chance. So what you need is a controlled release. Controlled release of the drug balances the need to inhibit these proliferating smooth muscle cells, but at the same time, it allows the intima to grow, the endothelial cells to grow, reducing the risk of late complications such as thrombosis. And these are some of the early trials in the early 2000s of the drug-eluting stents, which came before drug-coated balloons in the below-the-knee segment. And you can see with that, with the figures on the extreme right, that they were very promising studies. All of them are, not one of them is against drug-eluting stents below the knee. But the trouble is that if you were to pay attention to the fine print, these were lesion lengths in the range of about 30 millimeters, which is not typically the lesion lengths we treat, as has been established by various speakers, in the below-the-knee segment. Now, the other thing that I don't think has been adequately spoken about, and it's only appropriate that in a symposium that's dedicated to drug-eluting technologies, that we take a moment to pause and reflect on the word elute, its meaning, its implications, and its kind of understated elegance. The word has a Latin root. It means wash out. It is a term that started off in chromatography, which necessitated that there's a gradual release of the substance into the neighboring structure. And therefore, when we're using the word elute or eluting, there has to be a gradual washout or a gradual release. And therefore, in my view, my submission is that I don't think we should be conflating DCB and DEB. There's no such thing as DEB, except one, and we'll talk about it, because there isn't a balloon that gives you slow, controlled release. It's a one-time delivery of a payload into the vessel. So I think we should always refer to this as drug-coated and not use them exchangeably or fungibly. Now, why are below-the-knee lesions different? This is a very interesting study. Peripheral arteries from 95 patients following amputations. So there's about 121 amputation specimens in 95 patients were examined. And the pathological characteristics were separately recorded for the femoral, popliteal, and infrapopliteal arteries. And what you find is that in the femoral and popliteal segment, above the knee, there were atherosclerotic plaques. But what you had below the knee, suddenly it becomes medial calcification. And it's I don't have a pointer, but it's exactly the middle picture in the slide. The two arrows point to the gray zone, which is medial calcification. The other thing that this study reveals is that there is luminal thrombosis in the tibial vessels. Remember, these are 125 amputation specimens that had to be amputated for CLTI. And they're doing studies and sectioning of the vessels to see what these vessels reveal. So first, there's a significant medial calcification, not that much of atherosclerotic plaque burden. It's counterintuitive, but that's what the study shows. And secondly, there's luminal thrombosis, as some of these slides will, some of these pictures will show you. Now, the reason this is important is because, and this is the peculiarity of the BTK segment, that lipid, calcium, and thrombus are diffusion barriers for the drug to get into the artery. And so you have to ask yourself the question, what kind of vessel prep is possible in the BTK segment before you blow it up with the DCB? So again, data from that study, if you were to pay attention to the red marked areas, almost 70% of the BTK arteries have medial calcification, as opposed to a completely low figure in above the knee vessels. And in almost 50% of these specimens where there was medial calcification, the calcification involved more than 50% of the circumference of the artery. And almost 70% of the BTK arteries in this study were found to have some kind of thrombus of some age, in addition to calcification and some atherosclerotic plaque. So that is the other information we need to park inside our heads before we try and analyze data on the BTK segment. And before we evaluate the evidence, we should also consider some of the endpoints that we are discussing and when we are specifically speaking about outcomes. So one is binary restenosis. This word is bandied about so many times. The term binary refers to a simple yes or no outcome. So binary restenosis means whether restenosis occurred or not at a predetermined threshold. You determine that threshold, 6 months, 12 months, whatever. Was there restenosis? Percentage of restenosis is not relevant. So a lot of these studies will throw figures at you which will say binary restenosis, but evaluate that it's not a clinical parameter. It is a purely angiographic parameter. You do an angiogram after 6 months or 12 months, and then you decide whether restenosis happened or not. The other is late lumen loss. So you started with a lumen of whatever, 3 millimeters, and by how many millimeters did you lose that lumen at a predetermined interval? Again, this is an angiographic parameter, nothing to do with clinical symptoms, and it's calculated in millimeters. So this is the second endpoint that is thrown at you. The third is obviously target lesion revascularization or clinically driven target lesion revascularization. In my view, this is the most important thing because we've understood the complexity of BTK lesions. The patient came to you for a clinical symptom and seeks a re-intervention. And if you were to do it, that is CDTLR. As opposed to, you do an angiogram, you find something, you treat it, the oculostenotic reflex. Now, once we've understood that, so we must ask, without prejudice or preconception, to what destination does the evidence compel us to go? And before I start that, I'm going to throw this at you, and this is largely because I received this gyan a couple of months ago from my wife, who's more invested in research. We must always look at the p-value. And I'm going to show you the studies, and you'll realize why this is important. Now, I had no idea up to, till a couple of months back, why a p-value of 0.05 is taken as a marker of significance. First of all, what p less than 0.05 means is that there's a 5% chance that the observed result could happen by random chance. So if you were to just flip a coin 100 times, if you were to get a desired outcome that is less than 5% chance, that means that this is not governed by chance. It is governed by your intervention. I'm doing something while flipping the coin, which is going to determine the outcome rather than by random chance. And the particular bit of gyan that I realized was that why is this arbitrary? It's a completely arbitrary cutoff. Why can it not be 0.03, 0.01? It is because the 5% chance comes from the two tail ends of the bell curve. You'll see 2.5% on the left and 2.5% on the right. What lies in the middle is normal occurrence. The outliers is what are governed by chance, and therefore you add 2.5 and 2.5, you get a 5% chance of a random occurrence, and that's why p less than 0.05 is considered clinically significant in biostatistics. Armed with this information, let's look at the evidence. And a lot of this is what Dr. Edward Choke and many others have shown you, but let's scrutinize this information. This is the first prospective randomized control trial that was carried out with involving DCBs in the below the knee segment. It's called Debate BTK. And you find that the results are encouraging. There were about 132 participants. And again, what are the outcome parameters? Binary restenosis rates, which are better. Target lesion revascularization, not clinically driven, remember, which is better. But no significant differences in major amputation rates. So you've got two excellent parameters on angiograms, but made no difference to limb salvage. Okay, this is bandied about as the most successful BTK DCB trial. How to interpret it? Up to you. Next, this happens. So, Debate BTK was in 2013. Next, this happens. This is the IMPACT DEEP trial, 12-month results, 358 participants. No significant difference in CDTLR, late lumen loss, or 1-year binary restenosis rate, all angiographic parameters. Increased major amputation rates in the DCB arm compared to that of the PT arm. But look at the p-value. It's 0.08. It is not less than 0.05. So this looks bad numerically, but is not statistically significant. But in view of this, the balloons were called back, as we know. We move along the timeline, 2015. This is the Biotronics first-in-man study using the Lux DCB. 71 participants, not very impressive. None of the primary endpoints were met. So see where this is going. This is not looking promising at all. The best trial, Debate BTK, just numbers thrown at you, no difference to humans, okay? No difference to your patients. Again, this one, so none of the primary endpoints were met. And then this is dropped. The Katsanos meta-analysis and systematic review, this was published in the Journal of the American Heart Association in December of 2018, and it investigates the long-term safety in DCBs. Now, 28 randomized controlled trials, roughly 4,700 patients, and remember, almost, this is across the board. This is not just BTK, this is SFA, popliteal BTK. But 89% of these studied were done for intermittent claudication. All right? What did it show? At 1 year, the all-cause mortality is the same, no difference. But as you track these patients along the natural course of their disease, at 2 years, there is a 7.2% mortality for drug-coated balloons versus a 3.8% mortality for non-drug-coated balloons. At 5 years, the mortality almost doubles to 14% for drug-coated devices versus 8% for non-drug-coated devices. All right? So this development, the Katsanos meta-analysis, very dramatically repositions at least paclitaxel devices, demoting them from the pedestal of kind of heroism on which they were placed to the ranks of the villainous in the narrative of drug-coated technologies and vascular innovation. The other thing that the Katsanos meta-analysis revealed was that higher doses of paclitaxel were linked to higher risk of death. So there is a predetermined dose per millimeter of the balloon, coated on the balloon. And there are, so IMPACT DEEP has about 3.5, I think Lutonics has 2, these are micrograms per millimeter, 3.5 versus 2. So the ones that used higher doses were linked to a higher risk of death. That's the other thing that the meta-analysis revealed. It dropped a bomb. But in the meanwhile, people didn't stop. I mean, there was this other trial that happened with Lutonics. This is from 2019, 442 participants. And like other trials, this one also does not meet the primary endpoints. As a saving grace, it establishes the non-inferiority. Now you're speaking of non-inferiority of drug-coated balloons below the knee compared to POBA. In response to Katsanos, Zeller et al. Bring this in, which is the 5-year outcomes of the IMPACT DEEP. Remember, not impressive study in the first place, which established that numerically there were higher amputation rates, And a 5-year follow-up reveals the following, that numerically, again, the amputation rates were higher for DCBs, but look at the p-value, 0.108. It's not clinically significant, but at least it's established that it was not linked to higher mortality. All right? And I think this was Zeller's 5-year follow-up, which was built into the original study, and which should have come out earlier, comes out later almost as a response by the industry to Katsano's meta-analysis. Then you have the Chinese stepping in. This is Acotec, which is China's first drug-coated balloon. This is a study published in 2020, sponsored trial, okay? And it gives us some good news that all the primary endpoints were met at 6 months and 12 months, all right? The p-value is significant. And after a succession of rather unimpressive trials, this is the first time a real trial, though sponsored, comes in with significant p-values that gives some advantage to DCBs at the end of 12 months. And this is a follow-up study to the same. Again, 87 participants. And this is important because the lesion lengths here are more than or equal to 15 centimeters, 150 millimeters. And you can see that this is the same follow-up. The Chinese are able to show us that they can use their technology of paclitaxel is able to give you decent results at 6 months and at 12 months with significant p-values, okay? This was important for Asians because we're looking at an Asian population now. But considering that the earlier was a sponsored trial, the teams from Singapore decided to weigh in with a physician-conducted trial. 2 tertiary hospitals in Singapore come out with this, the Singa-Plackley trial. This is of interest because, as I said, it's the Asian population and a physician-led trial, not sponsored by industry. It's supported by the National Medical Research Council of Singapore. And this is a dampener again. None of the primary endpoints were met. So the only, as a summary of this, the only trial to establish clear supremacy of drug-coated balloons in the BTK segment is a sponsored trial from China. Now, believe that if you might. But what happens in the wake of the Katsano's meta-analysis? Because all of us would be concerned about, is there a mortality risk to our patients? Katsanos publishes his meta-analysis in 2019. The FDA writes 3 warning letters to all physicians and calls for further investigations. A panel is set in, and subsequently there are, in 2023, this is another meta-analysis by Sahil Parekh et al., which shows that there is no association between paclitaxel-coated exposure and risk of death. It's a significant meta-analysis, so 2,600 patients, almost 5 years follow-up. And it's now, following this, last year, that the FDA has removed its red flag from drug-coated, paclitaxel-coated balloons for its mortality signal. But the British have still not done it. The MHRA in the UK still hasn't updated this, which is do not use paclitaxel drug-coated balloons or stents in the routine treatment of patients with intermittent claudication, as the mortality risk generally outweighs the benefits. And the amputation risk was partly because of this, the slow flow phenomenon, which we've all spoken about. This was a single center observational study, 88 FEMPOP lesions. This is not relevant, but I'll just show you why this is important, that all the slow flow groups ended up badly, okay? And they tried to find out what causes slow flow, but one of the important things was the length of the drug-coated balloon and the drug that is being given. Why does that happen? This is an animal study that tries to explain this. This is, they used Impact Admiral and Lutonix in a pig, okay? And they then subsequently sectioned up the pig and saw what kind of fibrinoid necrosis happened downstream in the tissues. And they found that in Impact DCBs, it was in 46% versus 0 in Lutonix, okay? And that was because, and also there was higher concentration of the drug in the impact in pigs in non-target tissues. This is what it looks like. And they said that it is because of the technology they're using to coat their balloons. If it's crystalline, it has the potential of distal embolization, and also the dose. Lutonix had a low dose, and Impact Admiral had a higher dose. All right? But again, you can see that this was a study funded by Lutonix. So no surprises here. I'll move to the end very quickly. And this is what we need to carry back home, that all men and women are not created equal, and not all drug-coated balloons are created equal. A class effect cannot be anticipated. The right excipient polymer is perhaps the secret sauce. It's this paper on the pharmacokinetics of paclitaxel was established that this is the kind of particulate formation, you can see the image there, that happens following paclitaxel balloon inflation in Ranger, Lutonix, Impact. And the area under this graph is how quickly the drug is taken up and how long it stays there. It's different for all three balloons. So not all drug-coated balloons are the same. And what is needed in a drug-coated balloon? You need immediate increased drug uptake, you need extended drug retention, and you need to limit drug embolization. Anybody recognize this man? So, in the year of the moon landing, 1963, soil samples from the Easter island of Rapa Nui arrived on the desk of this 37-year-old Punjabi microbiologist in Montreal. His name was Surendranath Sehgal. Okay? Sehgal and his team isolated some microorganisms from this soil and grew them in his lab and examined the chemicals that the culture produced. And what they found was a yet unknown compound secreted by a bacterium called Streptomyces hygroscopicus that showed astonishing results. That was called rapamycin because it came from Rapa Nui, which is now known as sirolimus. So we have this man to thank, a Punjabi microbiologist, for sirolimus. And limus is a powerful immunosuppressive, an anti-migratory, and anti-inflammatory agent, most importantly. So this might have promise below the knee. It is used extensively, sirolimus or rapamycin, for suppressing the immune response in organ transplantation. And the wonderful story is that this man, Surendranath Sehgal, at the end of his life had colon cancer, which metastasized to the liver. He was admitted in a Pittsburgh hospital where he was supposed to undergo radiofrequency ablation for the liver tumor. And in the liver unit there, while he was recovering from the RFA, the floor had transplant patients, liver transplant patients. And word soon got out that the discoverer of sirolimus was admitted there. And soon enough, people came in wheelchairs to shake his hand that, thank you for saving our lives. But anyway, sirolimus is the drug of the future below the knee. As has been established, it inhibits the smooth muscle cells most vigorously. Some of the newer balloons that have been made have sirolimus with this kind of technology. It's like sirolimus being on a sticker. So because it's on a sticker on the balloon, I mean not a sticker, but on a nano level on a sticker. So when it's conveyed to the location, which is distal, which is the below the knee segment, it doesn't get washed off the balloon. And when it is inflated, it's like a sticker on the other side, so it goes and sticks to the artery and moves within the vessel. It's a phenomenal nano encapsulation delivery, so the crystallization doesn't happen, and therefore microembolization and slow flow is not seen. What we have now is purely observational data from sirolimus. The randomized control trials, particularly below the knee, are still enrolling. Some of them are being completed. This is what it looks like. It's observational data. This is the solution observational data. This is the ecstasy trial that Dr. Chok was speaking about. It's looking good, but remember that these are observational studies. These are not randomized control trials. And we're yet to see the results of randomized control trials specifically addressing the multifarious complexities that determine outcome. And I'll go back to Mustafa's data. This data, again, 6,800 patients, we have to deliver results better than this. At the moment, we have no evidence below the knee that can make you sit up and take notice. So drug-coated balloons, despite all the fanfare and lofty claims, have yet to decisively outshine the humble, plain old balloon below the knee. Thank you very much.
Any questions?
Sorry for the long-winded thing, but...
It was a masterly exposition, thanks. If I could use some big words too. So one question, having looked at this data, why do you think there's such a difference between what Castaneau showed and what the subsequent meta-analysis showed? Was his data flawed, or are we having a kickback?
One of the criticisms of Castaneau's analysis is that he did not figure in crossovers. A lot of these patients, so the trial ends, but many of these patients have come back, and they've now been treated with something else. Like someone who was subjected to a POBA would have been subjected to a drug-coated balloon. None of these crossovers were studied. So it was done on an intent to treat basis rather than what actually transpired basis. And that might have flawed. I'm not a biostatistician, so I can't very closely scrutinize what exactly is to be read out of it, but this is one major criticism of Castaneau's meta-analysis. So,
Amrish, nice, thorough talk.
Thank you.
One question you mentioned about SAD and completeness of plantar arch. Any correlation with pedal acceleration time?
You know, we are working on a study. Pedal acceleration time is an excellent indicator of limb salvage and wound healing. But we don't have robust data, and particularly with DCBs, one wouldn't know. But definitely it's a factor to be considered. So it's studied in the vessels of the foot and the time taken, the curve, pre and post intervention. And the acceleration, you have a cutoff which will determine whether it is going to lead to. So it's an ultrasound probe kept on the possibly the one of the tarsals. You can determine it has to be the same vessel studied before the intervention and after the intervention.
All pedal vessels, Rahul, you put it, and kind of correlates with ABI, but again, with people with so many wounds on the foot, it's difficult, especially in diabetics, heavily calcified vessels. So PAT is much better indicator pre and post to assess your completeness or effective therapy.
So what are the values we are looking at? So definitely we know that the peak systolic velocity is what we measure in before and after intervention there will be peak systolic velocity. Is it the same or the time is different?
No, the acceleration time, the slope, the rate of acceleration is calculated.
Yes,
and we never, so PSVs we evaluated the ankle, right?
Yeah.
PSVs we evaluated the ankle.
Mm-hmm.
PAT is done in the foot, in the arch.
Okay.
Right, so it's much distal. So you need to find out what's happening beyond the ankle.
Mm-hmm.
At this point, it's only PAT or perhaps other kind of softwares when you're studying the flow of contrast, and that might give you information. But this is the most inexpensive way. In fact, if Nikhil will remember, I think we were in talk with Jill Somerset, who's basically
so
worked
you
a
read
lot
that
in
paper by Jill Somerset.
Yes, and
it categorizes 4 classifications in ischemia, and the worst, of course, is class 4, where your acceleration time is so poor, or you cannot. There is no flow impact.
Yeah, because you see, what happened, I'm talking, I don't know about this, I will read about this, PAT, and in the clinical setups, if you have on a Doppler, a pulsatile, even the most calcified vessels you can see on a Doppler, higher resolution Dopplers, that it pulsatiles. And you put in a color, you have pulsatile flow at the ankle. So normally the success rate is very good. But there is a group of people where even if you have a pulsatile vessels at the ankle and angiographic looks nice, but still you got a very severe, like CRF patients, very severe distal disease, and patients, the wounds still don't heal. So my question is like, does this PA acceleration time will help in this group of patients,
Absolutely. So what you need to find out is SAD and MAC. And there's a third subset of patients which will have an actual impairment at the tissue level because of AV shunting. In diabetics, you'll get palpable pulses, but they'll be dieback as you keep,
Sir, if I may add, pedal acceleration actually factors in both the inflow and the outflow. Because if the outflow is impaired, the acceleration time is affected by that also. So I think because of these two things, it's a better indicator of wound healing overall, and that has been established. But obviously it's an ongoing process, and we have more studies coming in with that.
No, I think in the next VSI we should have a talk on this and on how to measure it, what will be the clinical significance.
We can even get Jill Somerset to join us online if you want that.
Yeah, why not?
Why online? I mean, we're beyond the pandemic now. So, I mean, we can
like, sure. I think this is something we are all struggling. We need to know about it. And I think another thing is we also need to look into it.
Another paper by
Mm-hmm. I think we need to find a group of tests where we are able to TCPO2, PAG, and ultrasound high resolutions velocities in the plantar artery. So what are the things which we can use in the day-to-day clinical practice on table? Like you do the angioplasty and decide, yes, this is my success, and will the wounds heal or not, like in a prognostic way. So we all should be able to use it in the clinical setups.
Hopefully we should be able to come out with some sort of...
PAT is a good concept. I've read it, as Rahul said. Any comparison of PAT and TCPO2, or do you compare the opposite limb or upper limb like?
TCPO2 is entirely flawed in my opinion, because there's so many confounding things that could. I mean, the temperature of the room. How do you control for that? Where would you find an exact in patients who've got? I mean, it's that, and so it's not a reliable indicator in my view. I mean,
any standardization of which vessel is, or any part of the pedal arch, or any vessel particular to a ulcer or something like that, anything like that.
Yeah, there are 3 points where you see it, but yeah, I mean.
Wonderful lecture, Amrish. You always leave us stunned. You've used the same statistics to demolish what all was quoted for the past 1.5 days. Okay, that's why I keep telling you statistics, all lies, can be manipulated. Do we have the intelligence to really understand the statistics, or we depend on the sales representative to tell us this is right? That is why, always a counterpoint like this is very, very helpful. And regarding what Rahul said, we as vascular surgeons constantly think you improve the blood supply, you heal the wound. It can't be more wrong than that. Okay, all your plumber is you just improve the blood circulation. We are not understanding the physiology or the advances in wound healing which are taking place inside the body. Small vessel disease, choke vessel, sympathetic overactivity or inactivity leading to shunting of blood from the arteriole to the venule without going into the tissues where it really needs to go. We have seen patients. You've shown the diebacks also. Palpable DPA, you've done a wonderful thing. All the arch is open, but the tissues continue to die. I think every conference like this, once you have this, you must have one session on wound healing, so that over a period of 2 years or 3 years, we will learn more about wound healing.
Right. Thank you. Clinical outcomes, when tabulated, will have to be statistically significant, right? No.
I'm sorry.
Yeah.
In the sense that statistically significant may not translate into a clinical.
No. So clinical significance is for an outcome, a single outcome, an outcome. But statistical significance is when you're comparing two things. So take any variable. Limb salvage is your clinical outcome. If the limb salvage is a certain percentage in the DCB group, and it's a certain percentage in the POBA group. But on statistical analysis, the difference is the p-value is not less than 0.05. The two interventions are the same. As I said, that any difference is because of random chance, not because of the intervention. Do you understand? So for a single outcome, for an outcome, you might note it down, but when you were to tabulate it and assess that information, you will have to apply principles of biostatistics to it. You know?
Thank you very much, sir. We move on to the next speaker. Dr. Danesh Kamerkar, sir, will speak on experiences with BTK stenting.
Morning, everybody. Thank you, Bombay guys, for arranging this nice symposium. So I'm going to share my experience of using stents in below-knee arteries. I have no disclosures. When we look at critical limb ischemia, it's a multi-vessel, multi-level disease with challenging lesions, especially in diabetes and renal failure. And if untreated, almost 50% are major amputations, causing increased morbidity and mortality. Endovascular revascularization reduces morbidity and mortality as compared to bypass. And BTK disease revascularization needs better patencies if there is a large tissue loss. Stents do play some role to achieve this in below-the-knee lesion. If you look at the anatomy here, BTK arteries, they are frequently involved in CLI patients, especially in diabetics. So far, it has been a no-touch area for endovascular treatment, but it's because of small vessels, long lesions, and calcifications. But there are tremendous improvements in hardwares made in recent years, like dedicated guide wires, balloons, and dedicated stents as well. And we heard Venkatesh about using bioabsorbable, resorbable scaffolds. So there are multiple varieties of BTK lesions. Many could be 50% long occlusions, more than 10 centimeter. They are severely calcified and undilatable lesions. And there are different stents, which could be like balloon expandable or self-expandable. And when we look at this, I'm sure all of us have seen this diffuse disease in the tibial arteries. It's very rarely you would see a very isolated stenotic lesion in just a single tibial artery, and that's extremely rare to see. Especially if they're short lesions, whether the angioplasty or stenting, that's a question. And if there are ostial lesions involving tibials, whether to do only angioplasty or whether they need a kind of kissing stents. And if the long lesions, what do we do? So these are some of the examples of self-expanding stents which we do not have these from biotraining. So when we look at BTK stenting, generally it's considered as off-label use, and it's a bailout technique for flow-limiting dissections when after the angioplasty, or if there's a restenosis or recoil after balloon, or if there's suboptimal angioplasty or atherectomy results, then one could think of doing as localized below the restenting. There is a significant data that BTK stenting is effective and durable primary endovascular strategy for CLI patients, which could be either a balloon expandable or self-expandable. And what are the tips and tricks? Obviously, we have to consider stenting from healthy to healthy vessel. When we are using drug-eluting stents in bifurcated lesions, always use it as a kissing stent, otherwise there can be atheromatous plaque shift to the other artery. It's like when we do a common iliac, the similar kind of strategy used here. Better to use one long than overlap, and if there is overlap, use it should be at least centimeter. For balloon expandable stents, dilate to 1 to 1 to 1 ratio. And for self-expanding stents, one size larger than the vessel diameter should be considered, and post-dilatation with balloon half size should be larger than the stent. So these are some of the practical tips. Should be adequate distal runoff below the ankle and foot, because if there is no runoff going into the ankle and foot, then probably no matter what you do, it's going to close off. Vessel caliber should be at least 2 millimeter, and that is why stenting, especially in the lower third tibials or going into the foot, is kind of not desirable. Stented vessel should be dominant vessel feeding the foot or feeding the non-healing ulcer, and that's important thing we have to look at. When we prepare the vessel, it should be an adequate angioplasty or atherectomy. Sometimes we use nitroglycerin, giving locally in the tibial vessels 300 to 500 micrograms, and stent 3 centimeter above the ankle should be at least placed. Anything beyond that, one should not consider stenting, and also avoid across the big branch. If vessel size is less than 2 millimeter or poor distal runoff input, don't think about stenting. So it's my experience at one center, retrospective study, observational. All patients who required BTK stents in last 4 years we included. There were 25 patients, 28 limbs, and primary findings were limb salvage, and secondary findings were amputations, wound healing, and reinterventions. Common hardware which used is .014 and 018 wire, and stents were either balloon expandable, which were mainly coronary drug-eluting stents, and 2 or 3 patients where we used part of the Merrill trial, which we used bioabsorbable scaffolds with the diameter range of 3, 3.4, and 4 mm. And these were the length from 28 to 48 mm. And balloon size generally would be 2.5 going up to 4. Just an example of TP trunk occlusion with a good runoff and putting a drug-eluting stent in the TP trunk, and nice results. These were the results. So commonly around 66 was the mean age. Again, more in males, we saw only 4 females. Majority had diabetes and hypertension. 12 patients had ischemic heart disease, and excuse me, 4 had CKD disease. Commonly, what we saw was more on the right side of the body, and 8 left legs were injured, and 3 in bilateral limbs. The disease overlap and disease pathology: 13 had SFA stenosis, 14 had popliteal stenosis, 23 had TP trunk stenosis, and 19 had TBLs. And it's an overlap of all these anatomical lesions. They all had drug-eluting stents. 20 patients had everolimus. No, I have, thanks. 20 patients had everolimus drug-eluting stent, which is almost 70% majorly. 2 had sirolimus stents, and 2 had zotralimus. All were coronary stents, drug-eluting stents which were used. And the best advantage over a period of time, what we realized, because the cost-wise, since the coronary stent prices came down, it was fairly fitting it into all the outcomes and budgetings. 17 had a gangrene of the toes, and 11 had non-healing ulcers. 7 patients out of these did not require any amputations, 20 had minor amputations, and 1 had a major amputation of all 28 limbs. If we look at the postoperative wound status, 23 had healed completely, 5 did not heal, and 27 patients we achieved the limb salvage. 1 patient had to undergo amputation. Out of, when we consider mortality, 17 patients survived, and 8 were died because of all-cause mortality. Now, this is the incidence of amputations according to type of drugs. So, 4 patients did not have any drugs, and out of those, 4 had minor amputations, no major amputations. The one who had everolimus drugs, 6 patients did not require any amputations, 14 had a minor amputations, none had a major amputation. When we used sirolimus stents, one did not require an amputations, nobody required minor or required amputations, but one had a major amputation. And zotolimus, none had amputation, two had a minor amputations, none again in major. So of all 4 cases with drug-free stents, all had minor amputations, and 20 with everolimus, almost 30% required no amputations, and 70% had minor amputations. When we look at the incidence of limb salvage as per the type of drug which was used, again those who did not have drugs, all 4 we could salvage the limbs. Everolimus, 20 patients used, and all 100% had a limb salvage. Sirolimus, 50%, because there were only 2 patients we used that, and zotolimus, 2 patients, all were salvaged. These were the segments which we stented, BTK. Popliteal, distal popliteal had 5 patients. Out of that, 1 did not require amputation, 4 had minor amputations. All 5 had a limb salvage. When we stented the TP trunk, out of 21, which is most common segment to be stented, 5 did not require any amputations, 15 had a minor, and 1 had a major amputation. So almost 20 had a limb salvage. And when we used stents in 2 patients in anti-tibial artery proximal, 1 did not have an amputation and 1 minor amputation. Now the 6 patients required re-interventions from all these 28 limbs. And very interestingly, the observations were that many of all the 6 had a SFA stenting and drug-eluting stents, BTK in TP trunk. And the observations, which I will show you a couple of examples later towards the end, that all the BTK stents were patent in all re-interventions which was seen, but the occlusions were proximal SFA stents in all 6 re-interventions. Out of these re-interventions, 1 patient we did SFA popliteal drug-coated balloon, 1 we did a distal bypass, 3 patients we did mechanical thrombosuctions, and 1 patient we did mechanical thrombosuction and SFA stenting again. Now 4 patients out of 28 required re-interventions. 2 of them had a severe ischemic heart disease with LV ejection fraction less than 30% and had a myocardial events, peri-procedure, probably that's the reason the EF dropped further and had occlusion. All-cause mortality after re-intervention was in 1 patient, and all had TPT drug-eluting stents. Those who had patency was noted at all 6 re-interventions. So primary patency 28%, secondary patency 21%. Duration less than a year, 14% had a patency less than a year, 85% had a more than a year. The duration of wound healing, those who didn't have any drugs, out of 5, 18% almost percent of wound healing, less than a month, 7.1%, which are 2 number of patients, 1 to 3 months, 7 patients, 25%, 3 months, 14 cases, and 50%. When we look at angiosome-related or directed revascularization, 22 patients had direct revascularization, out of which 21 could be salvaged, and indirect revascularization, 6 patients, all 6 were limb salvage. So limb salvage was achieved in 27 limbs, whereas 1 limb required major amputation. Postoperatively wounds were healed in 23 patients. In 5 patients, wound healing was not achieved. There was associated mortality in these 5 patients because of mortality unrelated to primary procedure. All-cause mortality was almost 30% in 8 patients. 4 patients required re-intervention, but the culprit lesions were, 6 patients were required re-intervention. Culprit lesions for re-intervention was in SFA in all of them. We could just compare our findings to Paradise and Basil 2. So I'm just going to go through these quickly. So our study, amputation, major amputation, only 1. 8 patients had all-cause mortality. 21 patients had a complete healing. and relief of rest pain in 26 out of 28 patients. 35%, almost one-third, had a repeat angiographic evaluation following reinterventions. And when we compared with Basil trial, 6% was ours as compared to 15.9 in Paradise. And compared with the Basil surgical arm, 6% versus 13.9%. And so cumulative limb salvage almost 87%. It's a single center, single surgeon study, so limitations being a retrospective, recall bias could be considered. Our study findings match with the meta-analysis done by Sarvas, Nikiforos. The level 1A supports the use of infrapopliteal drug-eluting stents for short to medium length lesions. Wound healing in critical limb ischemia requires long-term patency that can be achieved with drug-eluting stents. So there are few trials, Dr. Venkatesh also showed earlier, Paradise, then many studies, meta-analysis have showed drug-eluting stents better than others. This is another meta-analysis, look at the outcomes, primary and secondary patencies. In all patients with infrapopliteal occlusive disease, drug-eluting stents result in improved 1-year patency and freedom from TVR, but not better survival or limb salvage compared with bare metal stents. It's another long DES BTK study published in Jan 2020 through Link. 10 years data used Zions everolimus, and amputation-free survival in Rutherford category 4, 5, 6 was almost 70% at 1 year. And for 4 and 5, over 90% amputation-free survival. For category 6, 50% only. This was from Raymond Warko, Angiology 2019, systematic review and meta-analysis, and use of drug-eluting stents in BTK arteries. It significantly improved primary patency, freedom from reinterventions, freedom from major amputations compared to BMS or drug-coated balloons, and sirolimus coating was better than paclitaxel coating. This is another study, Disappear, limb salvage almost 90%, 96% at 6 months, primary patency 93%, 1 to 6 months. And they use bioabsorbable stents in Asian population. Absorb BTK, we heard about it earlier, everolimus, the eluting stents, 38 limbs, and freedom from TLR 96, primary patency 96%. So in real world, BTK is more diffuse than focal stenosis. Now this is a study which I was part of as a PI as well, credenced BTK study, which major PI was Girish Varavdekar, our colleague. And the similar study, what Venkatesh presented, Esprit BTK, using bioabsorbable scaffolds in below the knee arteries. I think 30 patients we did it. These were some of the endpoints, and the results were quite encouraging towards the end of 3 years. Esprit 1 trial, everolimus again coated stents, no recoils, binary stenosis 12% at 1 year. Remedy BVS trial, there are different trials. Now this is, we're coming to the latest, live BTK and Esprit BTK trial, again initiated by Raymond Warko, multicentric CLTI patients, category 4 and 5, and proximal 2/3 of the leg arteries were considered first. And these were essentially to evaluate the use of bioresorbable scaffolds, and then it was converted to Esprit BTK trial, where it's a drug which is everolimus, eluting resorbable scaffold versus angioplasty for infrapopliteal arteries, which was published in October 24 in NEJM, and was found to have use of scaffold superior to angioplasty in BTK arteries. When we look at the reinterventions in my study, 6 had reinterventions, and a combination, all had a combination of SFA stents and BTK drug-eluting stents, and there was thrombosis of SFA stents at various intervals, but what we found that the stents below the knee drug-eluting remained patent. Just an example here, you can see the extensive disease here. This was stented with drug-eluting stent, and he came back a few months down the line. This was, I think, just after the COVID. He came with thrombosis, SFA stent. But when we look and go beyond that, we see that this stent, drug-eluting, has remained patent. At the second time intervention, runoff was good. And this is another patient, multiple diffuse disease in the SFA and tight stenosis in TP trunk with single vessel peroneal runoff. So we again put a drug-eluting sirolimus stent here in TP trunk, and then SFA was stenting here. And came back again for stent thrombosis in SFA region and progression of disease. But when we look at the distal angio here, this stent, in drug-eluting stent, has remained patent, although this stent went down. So we had to do a intervention and ballooned it, the SFA. We had to stent that as well. And this segment, which had a DES in TP trunk, stayed patent. Another example, again, SFA disease. This was again distal popliteal going into TP trunk, and that was again put in a drug-eluting stent there and SFA stent. This was the picture, end picture, and then again few months down the line he came with SFA stent going down, but when we took a distal pictures, the patent drug-eluting stent which was planted earlier. So SFA we had to open, put another stent, and the status of drug-eluting stent remained good. And this was a variable period from probably 6 months to up to 1.5 years, and a nice runoff. So in conclusion, stent in BTK arteries can be primary endovascular strategy in selected cases and pathologies. Drug-eluting stent is better results for primary patency. Everolimus better than paclitaxel coating stents. Is still off the label but used when indicated. Thank you.
Thank you, sir. We'll move.
Quick question. Your 32% mortality is at how much duration?
Over 3 years.
Okay. And the SFA stents that have gone down, have they all been balloon-mounted stents?
No, self-X.
So self-X drug-eluting?
No, but the drug-eluting were balloon-mounted. They are coronary stents.
So your SFA stents that you've used are all bare metal, non-drug-eluting stents?
Correct.
Thank you.
So that was an interesting observation, that all the 6 interventions, the SFA stent went down, but the distal stents were patent.
These are all bad zones for stents anyway. True. Where they've gone down. So,
but the point is, the drug-eluting stents remain patent. I mean, one would expect that if your proximal stent goes down, it's very likely your distal stents also could go down.
Thank you, Kamirkar sir. We'll go on to the next speaker, Dr. Sanjay Desai, for drug elution in other arterial trees, the current experience and evidence.
Good afternoon. For the last 24 hours, I think we've been eluding on drug-eluting devices, and I think most of it, at least for me, and how I have seen this meeting, thanks to Vessomag for conceptualizing this wonderful concept and bringing this awareness and interest among us, because this has definitely been thought-provoking. From whoever I've met and we've discussed over yesterday, I think it's definitely made it a little more interesting and also an understanding for all of us to know what we are doing. Having said that, I think what I'm going to talk to now and what we have been thinking about is what actually drug-eluting I think we have spoken about trials and what is in favor, what is in not favor. I think let's look at this talk in without any prejudice, without any pre-conclusions, because what I'm going to talk about is drug elution in other arterial trees. So when we talk about this, this is not about PAD, this is not about intervening in claudicants, intervening in Rutherford 5, 6, and various other data. But I think this is a special scenario where we need to look at whether these really work. Also, whenever we come out or research comes out with anything new, it's easy to write it off. It's always difficult to accept. I think that's something which we also should learn. Medicine would not be what it is if we had always looked at everything negatively. I think whenever a new technology comes, maybe we are overusing it, we are abusing it. It's not that it is wrong. It's not that drug eluting does not work or drug eluting is bad. I think it's probably we are abusing it. I think with that in mind, this is what I was talking to Robbie here. I said, I'm relooking at how I'm going to start this talk because this is what I understood and what we should be looking. So whenever technology comes, we accept it, maybe with a pinch of salt, maybe with a sack of salt, but then there is always scope for something which can be used in helping our patients get better. So having said that, I'll just go through the mundane talk of what drug eluting stents are. As usual, most of our studies and most of our work is borrowed from our coronary cardiology work. And so is this, because a lot of times it's used first in the coronaries and then we start to extrapolate it into peripheral arterial disease. And once it works there, then we start looking at other arterial trees. So that is how these have started, and that's how this has always come up. So we do start with the studies, we do start with counter studies, we do start with how we analyze these studies. And eventually, end of the day, before we are now talking about paclitaxel with sirolimus. By the time we have a verdict, we'll have another drug. So that's how medicine goes. It's always a constant change. So drug eluting balloons and stents offer innovative therapeutic options in managing conditions, may not be restricted to coronaries and peripheral. Like I said, we need to look at it probably, especially in scenarios like mesenteric, renal, carotids, because these are difficult areas. These are areas which are not really susceptible to reinterventions. These are areas which are critical. You cannot expect to fail here, and you want a good term patency. So these are the areas maybe these work. So this is not my verdict, but this is what I'm trying to analyze over the last 2 days with which we have been discussing. So the drugs, we all know the renal artery scenarios, the renal artery angioplasties, which are done for various reasons. But then how it started, Italy first did this in an acute renal artery occlusion. CT showed an extensive, its total occlusion in a previously stented artery. And using DEB in the management of in-stent stenosis may certainly better the superimposing another stent in a scenario like this could have been disastrous. So this is where it was used first, and it showed reasonable patency at 6 months. 6 months may not be good long enough, but then in a situation like that, he first used it and probably set the ball rolling, saying that, yes, there may be a scope for using this. Again, then came Granulli et al., talking about a bifurcation stenosis, again a single kidney, no other options, try to see how best we can help, and this is what he did. He put in 2 stents, saw that it was patent, and then let it go on. So here we don't really look at whether the patient survived, the kidney survived for 6 months, 9 months, or whatever, but then this is where it started, and this is how it sets the ball rolling. So then came these 2 studies, Takahashi and Yamamoto. Again, both spoke about angioplasties, and drug balloons have shown potential in reducing antiplatelet drug use and mitigating the inflammatory response. The same thing with the second study, basically reported a case series of patients with aortitis-induced renal artery stenosis who underwent multiple renal angioplasty treatment before achieving blood flow, similar to those after 2 years of drug balloon therapy. Of Of course, multiple studies have linked small renal artery diameter with increased rate of restenosis. Obviously, smaller vessels would not be so hospitable to an implant. So limitation of implants as also with the long-term antiplatelets which have to be used in this scenario. The GREAT trial by Marcus et al. Evaluated the effect of sirolimus stent-coated compared to identical base stents. Obviously, the results were good. Again, let's not look at it as a 5-year patency or a 6-year patency, but then it set the ball rolling. So many other stents, many other trials started coming in, which did show fairly good results, especially in scenarios like this. Because if you look at a renal artery and then it's re-occluded, and then you're trying to keep it open, it's a big deal, actually. Even a 6 months re-intervention, 1-year re-intervention should not be much of an issue as long as you can keep the kidney going. Leave nothing behind has always been the concept. I think that's when we always spoke about the stents or the balloons which are there, and especially in in-stent restenosis, the main limitation involves that it may require re-intervention when it comes to high restenosis rate. Prevention of in-stent stenosis in carotid, irradiated carotid arteries. Again, this is another difficult area, especially if it's been operated or irradiated. It's definitely a hostile neck, whether you want to go in and do anything, whether drug-eluting or a drug-coated balloons is going to be helpful in this scenario. Definitely, yes. I think this is somewhere where, when nothing is there, nothing is left, anything you try is always the best for the patient. So I think this is, again, a scenario where you could try, and you did achieve fair results when you started looking at the data. So a lot of cases reported, especially in carotid irradiated, post-irradiated carotid recurrent stenosis. So there are studies which quoting about 856 consecutive patients. Out of these, 9 had recurrent in-stent stenosis despite multiple endovascular treatment within a short period of time. And these patients were treated with drug-eluting balloon angioplasty for neointimal hyperplasia. Technical success, good, 100%. Peak velocities decreased. DEB may have a potential role in helping these patients treated, especially for in-stent carotid stenosis. Drug-coated balloon versus angioplasty in AV fistulas randomized trials, not looking very good. I think my next speaker, Dr. Praniti, is going to talk about stenting in drug elution in venous side. Whatever data I could pick up did show good results, but a little to be careful because these are bigger ones. They are delivered directly into the veins, and they tend to get washed out, especially in high-flow AV fistulas. So I'll be eager to listen to her talk to see what it has to offer to us in that scenario. Of course, like I said, in these scenarios, it has shown to be helpful in treating patients. Again, another difficult situation is the Takayasu arthritis. We all know how difficult it is. It was always a no for endovascular, for Takayasu, but then with growing endovascular, better technology, better equipment, lots of endovascular work being done. Again, very, very known for recurrence. And again, in these scenarios, it has shown that drug-eluting has worked, and it has shown good results in these situations. Again, few studies few case reports which have been reported with fairly good patency, and then looking at it over time, if you look at a 2-year patency, it's been fairly good. So I think, again, in these scenarios, it has shown to be of help in helping these patients get better or continue to remain patent. TRAS is another scenario because we have had a good series of TRAS, but we have never used drug-eluting balloons. But again, these are obviously patients who have had transplant, single kidney, and it's very, very important to try to keep that kidney open. And in this situation, definitely drug-eluting, it has helped, or probably if it has shown better patency, I think there is a scope for using this. Mesenteric arteries, again, I don't know, not many of us do mesenteric work and isolated mesenteric work. First of all, mesenteric is a diagnosis of exclusion, and then you have to pick your lesions properly before you treat them. and getting there is technically very, very challenging for mesenteric. And once you get there, and if you have to re-intervene, it's not an easy thing. And especially if you leave behind a stent, getting back into that makes it even more worse. So if we can use, or if drug-eluting helps us in getting better patency in this scenario, it's going to be fantastic for us. So for recurrent mesenteric artery ring stenosis, again, by few of the studies to quote how they started, just to see a case of mesenteric in-stent stenosis treated, and then the results showing. Then another study again, drug-eluting stent from the celiac trunk treated by drug-eluting stent, showing fairly good patency. I think these are the ones which set the ball rolling again for us, and then probably in 2022, European guidelines on mesenteric ischemia spoke about longer dual antiplatelet duration was introduced due to increased in-stent thrombosis associated with DS. However, questions concerning the role of DS in mesenteric arteries and optimal revascularization strategy in patients with an in-stent tumor remains unanswered. But I think as I go through the slides, I'll talk about lots of trials which we could pick up, which are ongoing. Like I said, newer drugs are it's already there, and this is a report from using zotraluminous eluting stent in cross mesenteric ischemia. These are optical coherence tomography studies showing that good patency, 1 year follow-up has shown absence of restenosis and a good covering of neointima. These are the two trials. There are no clinical directly comparing paclitaxel to sirolimus in mesenteric artery. Obviously, I think, like I said, these are few new ones, but doesn't matter which one works, but if it helps, then it is good. So both the Sirona and the Salutonin, first of all, spoke about the safety between the two. I think that's now more or less defined. We just need to see how that safety works or how the patency remains. So like I said, there are lots of trials which are ongoing for mesenteric ischemia. There are trials which are undergoing for renal artery stenosis. Obviously, these are areas which are critical, very difficult to get ethical approvals when we do these studies. So it probably takes a little longer time. But having shown that they are non-inferior and the safety profile is good, I think we'll see more and more results coming out. And probably Vessomag 3 or 4, we should be discussing more on this. So the key takeaways, I think DS and DCBs are transforming mesenteric and renal artery interventions. Like I said before, mind you, these are special scenarios where we are talking about, so probably they have better outcomes. So teletherapy improves outcomes and reduces restenosis. Of course, we need evidence, and evidence comes from data, and data is always interpreted the way we want. I think yesterday's talk, we said the pendulum can swing both ways, and we can make it swing the way we want. And we all know as clinician practitioners, we know how to get the patient to medical therapy, we know how to convince patient to surgical therapy or endovascular therapy. So this is also a data which we need to interpret the way we want it to, in the best interest of the patient. So end of the day, I think somebody asked, is it statistically significant or is it clinically significant? I think we all work for clinical significance. Statistical significance is only to have a medical legal covered, but I think end of the day, it's always the clinical significance we take home. Just to note the difference between these two, I think obviously stents should be used in areas which are really necessary, don't want to leave behind anything. The challenges with drug-eluting or drug-delivering drugs still remains that drug absorptions are difficult in calcified or inflamed vessels, especially in areas where we talk about Takayasu's or irradiated scenarios. Risks of long-term thrombosis due to permanent implants, and of course flexibility of stents, especially in tortuous mesenteric arteries or right-angle celiac arteries, still remain a challenge. Of course, it does provide stent-free alternative when we talk about DEBs. DES provides mechanical support with excellent patency. Both technologies are promising, but like anything, research is needed for long-term outcomes. So thank you, and I hope that we do see much more of these in helping the patients in scenarios. Thank you.
Thank you, sir. Any questions? Okay. Thank you, sir.
Thank you.
We'll not be taking the tea break. We'll be moving to the next session. We'll be moving to the next session. What's next? I would invite Dr. Praniti to be speaking on drug elution in the venous tree. Dr. Ritesh Gaikwad, Dr. Love Luthra, and Dr. Bhupesh Gar kindly come ahead as chairpersons.
Just don't let it.
Anyone who wants to have tea, the tea is served on top, but we'll be continuing with the sessions as per, because we just have an hour to finish.
One second. One. Yeah, just copy. Copy करके
डायरेक्ट चल जाएगा.
चल जाएगा. हाँ. Okay. Full screen. Yeah, let's go to the first line. First slide. And we start. Is that true? Yeah, should. Okay. Good afternoon, and thank you, Vessomag, for the kind invitation and giving me a chance to speak to this August gathering. And my apologies. Denying the coffee break was definitely not my idea. That is Anirudh's doing completely. Right. With that disclaimer, I'll try and be very brief. And we need not prove that paclitaxel or sirolimus is spreading the toxicity around here. We'll reduce the toxicity as far as possible. Okay. Drug elution in venous tree. The first time I was assigned this topic, I thought it was such an elusive thing to talk about. What am I going to speak? Okay. So always start from the basics whenever you are confused. It starts all with the neo-intimal hyperplasia. This is taken to be our bane of existence as far as all endovascular or surgical interventions are concerned. Right? What we are trying to forget is it is a positive adaptive response of the body to any vascular injury. The moment we take in our first breath, the fetal circulation itself is actually, the fetal circulation occludes by neo-intimal hyperplasia. And this is also the pathophysiologic response that we wish to reduce when we are introducing a therapeutic vascular injury. There are little bit of science behind it is, as usual, the hypoxia and the endothelial dysfunction. Frankly, this becomes more accentuated in a venous tree, leading to much more severe venous neo-intimal hyperplasia, which we have seen in chronic venous disorders. We'll end up with synechia, far more number of synechias and fibrosis than compared to a arterial tree. Conventional techniques, how we reduce the neo-intimal hyperplasia, as Rutherford describes it, they say that your tissue handling is always the reason behind a successful bypass or an occlusion of your vessel. So the severity is how much damage you did during dissection, how much injury did you cause to the tunica media, that's a layer of the artery, and how much of vasa vasorum did you destroy while handling the adventitia of the arterial wall. The veins have a very higher amount of vasa vasorum compared to arteries. And whenever we do a venous vein graft harvest, that is where we damage is the most. And that is why at an anastomosis point, we get the maximum amount of neo-intimal hyperplasia. With that basic knowledge, we can move forward. And so it is very easy to say that how do you prevent it? You reduce the vessel handling, meticulous dissection, and especially during endovascular intervention, no eyeballing of the lesion. If you think that it is going to be a 7-size balloon, go 6. If you think it is 6, go down 5, 5, 4, and in that manner you will never be wrong if you are trying to eyeball, and that is how you are going to reduce this effect of NIH. The last factor is prevention of low outflow. Always remember there is an inflow, outflow, and the conduit. So if you take care of the inflow and the conduit, and then finally the nail in the coffin is your outflow vessel has to be ensured that it is there. So do not blame yourself that, like, I did everything right, and why is the pedal vessel not picking up? Now coming to use of DCB. Most data of in venous tree has been from the dialysis axis, and it has got a variable result. Katsanos has been the hero of this meeting especially, and he has been mentioned in many talks. And in fact, I have put his review article actually to understand how we can improve our dialysis axis results rather than going into other meta-analysis. Venous bypass grafts, this has been given. They tried a smaller number of series, but I think very soon they realized there was no significant difference was seen between a plain POBA, or you stent the lesion, or you do a DCB, drug-coated balloon. Chronic venous thrombosis, that is something the latest result, anecdotal incidences have been reported in pulmonary veins. That is where, but you require a high pressure balloon there, bigger size, 14, 16, I think beyond 14, 12 it is not available. And you require bigger size of balloon. And the dose delivery of paclitaxel in such areas is going to be very huge amount. So that is why it is being used cautiously, little more off-label use. Hepatic veins, again there is an anecdotal incident. I almost considered an IVC thrombosis when we had an extremely sick patient, but thankfully we got away with a plain POVA and alteplase to some extent. Hepatic veins, where they have used is where they wanted to take up the patient for a liver transplant at a later date and did not wish to stent the hepatic veins. Again, as I said, mostly off-label use. At our Sir Gangaram Hospital and AHRR also, most 95% use of drug-coated balloon has been in arterial tree. This is a disclaimer that we barely use them even in arteriovenous grafts. Use of DCB is extremely selective cases. If there is a spot lesion which we do not wish to stent and there is a lesion collapse after a POBA, then only we do a DCB. Otherwise, we don't do it. What the real life data says. As I said, Katsanos, again, there are at least 2-3 articles and there are others also. There is a small series on drug-coated balloons. There is a small series on drug-eluting stents, and the bigger drug-coated balloons for dysfunctional vascular access. It is by Katsanos again, this review article, which has taken off from last, I think, 2012 onwards, as many studies, some 39 studies he has considered, and his pooled data has been used. To go back, to understand this, what he has described as actually a vascular access circuit. The point of stenosis, are usually the vascular access cannulations. In a AV axis, it is the vein which actually is the most stenosed part rather than the anastomosis. And in the AV grafts, it is the venous the graft vein anastomosis site is the site of most of the stenosis, or even the restenosis for that matter. So why do you see restenosis and restenosis? Again, because of the angulation of the anastomosis that we set in, and then transition from a low to high flow system. And surgical manipulation, which leads to the damage of the microenvironment. As I said, vasa vasorum needs to be protected more in the veins rather than in the artery. Of course, systemic disease condition, that inherent systemic disease that they come to you with, uremia, oxidative stress, and hypoxia, is a given in dialysis access failure. Plain POBA, it can lead to, very easily, it can lead to a very successful outcome. It can, again, generate a same cascade of events leading to NIH. The whole idea, again, I don't need to amplify it any further. This is the various balloons that have been used in this study. These are all purely paclitaxel-based data, and Lutonix, Impact, Apeto, Pasio, all kinds of them, and with how much of dose was delivered during this dialysis, during this balloon angioplasty, that has all been recorded. They took 39 studies, they included both AV graft, AV accesses, AV grafts, pure AV arteriovenous fistulas, central vein stenosis, very few studies. And the results, first RCT, again, they took 40 patients. The comparison was PCB is superior. Second one, again, PCB was superior. The number of patients increased from 200 odd. Then they started a subgroup analysis. They found AV graft again had a much better result than the veins showed a better result than the AV grafts. Then finally one study came from, I think, Slovenia, which said there was no statistical difference between plain POBA or you do a PCB. Jockman and all, et al. He was the first RCT which showed the worst results at the end of 12 months. Netherlands study which came out, I think this is 2015 or 16, it came out and said no, the worst results. And surprisingly, basically there is no cardiac toxicity has been, or an increase in the mortality rates by use of DCBs in dialysis access. That angle was taken care of. It did not add on to the mortality factor. Okay, the roadmap to successful PCB treatment, the site where you must use this drug-coated balloons was that the steps that you must use. And in this chart, they clearly show that the site where you must use, if it is the vein which is harmed, the entire vein, the stenosis site has to be addressed. AV graft, only the anastomosis site, arterial anastomosis, you need not do a DCB, you need to do a vein site, and maybe the outflow vein also needs to be taken care of. Central veins, not significant number of roadmap available for that. But first step is vessel preparation and dilatation. This decides whether your DCB is going to work well or not. This is one, just for an example, this is outflow vasilic venous stenosis. As you see, the site of the lesion is this much, and the POBA balloon is on your left, which covers between these arrows, and DCB is a little longer than the POBA, the balloon used for the POBA. So that ensures the success rate, and the lesion collapse will not happen after you use a DCB of a proper size. It has to be centimeter more than the normal balloon. Again, a couple of cases, what we did here, we did a complete angioplasty of the vein axis here, which had completely collapsed. It was an occlusion, and we did a DCB, and this is the posterior result. I think 3 months down the line, it is still working. This is again an AV graft at the venous anastomosis site. We did a DCB. Result is acceptable enough for the graft to work. We don't know how long it is going to really continue. So learning points. The only learning point out of this is data is still inconclusive. If you feel your lesion is going to collapse, then you have to change your strategy and then take in a DCB. There is really superiority of DCB has not been proved clearly. If it is a vein which is collapsing, the results are much better. And what is the next in line is to analyze the various subgroups, the data is coming up, the lesion characteristics again, to see which group will benefit most from this technology. Thank you.
Thank you very much, madam. Any questions? Thank you very much. We'll move on to the next speaker, Dr. Rahul Jindal, sir. Will be speaking on newer agents in drug elution, why and why not yet.
सीधा लग जाता है. हो जाएगा छोड़ दो बस 2 मिनट वेट करो दूसरे में डालना शुरू करो आई थिंक ये चल नहीं रहा है इसमें कॉपी कर दो ठीक है देखो प्ले करके देखना नहीं ठीक है ओके Yeah. Good morning. The talk will not be very long because it's all on the newer drugs. So we know about two things. Once you place a stent, what happens? So one, there is a dissections, exposure of the media, which causes a thrombosis. And second, the stunt strets which are there. So they actually stimulates the vascular smooth muscles to cause you neomental hypoplasia. So what we are talking about is to prevent these two very important things in our practice. So we saw this slide yesterday, the PTX and sirolimus. So I'm not going to go in detail here. And we now know why we need neoreagents, because there is a limitation of the drugs what we have. So the important drug paclitaxel has got some side effects, and sirolimus is not a very, very potent drug, and there is not a good drug distribution because of the lipid profile it has. So we need an improved efficacy and safety profile of the drugs. And of course, there is a lesion problems like calcifications and smaller vessels. We need the neoreagents who has better tissue retention, minimize systemic toxicity, enhanced anti-inflammatory and reparative properties, and compatibility with advanced platforms. There are a huge amount of advanced platform which has come up. So look into these classifications. So we have heard just now, so we got sirolimus, everolimus, jotrolimus, and we also got biolimus A9, which is also being used now extensively. So we have got calcineurin inhibitors like tacrolimus and the punicrolimus, which I have never heard of before. So I read it for Shekhar. So microtubule stabilizer, we got, paclitaxel, which we use routinely. And there is something new which has come up is, I don't know, anybody who have heard is EPC capture. Anybody has heard of EPC capture? This is endothelial progenitor cell captures. So it's a very interesting technology. We'll go through this, okay? So what is the mechanism benefits of neoreagents? Is anti-proliferative effects. We don't want the vascular smooth muscles to come there. We want the drug to go in, and we also want a targeted action. But at the same time, we also want the new intima to come on the stent. Because if the new intima is not going to come, you're going to have an earlier thrombosis. So these are the basically 5 technologies where the world is going. One is the biolimus, where we have widely adopted in some regions now in the world. Jotrolimus is being incorporated in the Resolute Onyx stents now. And novolimus is in the early phase clinical trials. And the gene-based therapies and combination therapies, they are in the experimental stages at present. So let's see the 7 to 8 things which I have talked about. So let's talk about biolimus, what it is. We haven't heard about this in 1.5 days. So it's important to learn about newer technologies. So it's a biodegradable polymer. It's a semi-synthetic analog of sirolimus. You see, most of the newer drugs which are coming up, they are not based on paclitaxel. So they are all based on sirolimus. It has got higher lipophilicity, which is important because the faster tissue uptake and shorter systemic exposures. And there have been 3-4 studies which I have mentioned here. I don't want to go in detail about that. And all showed that in some study it showed is equivalent to sirolimus or it is better than sirolimus. And it reduces inflammation and faster healing time. So why are we not using it?
because it has got a longer term data we still don't have. Another drug is coming up is a jotarolimus. So it is also a rapamycin derivative, similar to sirolimus, and it also has got potent anti-proliferative effects. It has been actually integrated into the Resolute Onyx stent now, and it has got a shorter drug elution period, which is very important for us, and minimal delayed healing, but still under analysis, and the data is being collected with this drug. Then another drug which has been studied is a novolimus. It's another drug which has got enhanced lipophilicity. So the drug can go inside very fast inside the vessels. So early clinical trials are being done, tested in biodegradable polymers. So basically, we don't want the metal to be there. So most of the newer technologies are going into biodegradable polymers with faster drugs going inside and not very strong anti-proliferative effects, but and less cytotoxic. So still limited clinical adoption because of lack of large clinical trials. Another one is an everolimus. Now this is being used now, and as a routine practice, it's being used in India also. And I think future studies are warranted to compare the results with the sirolimus drugs. Then a tacrolimus based, which is a calcineurin inhibition drug. So this is not based on sirolimus, though it is limus, but it works in a different ways. And it actually binds to FKBP12 protein. So, this chemical pathway you can understand yourself or read it on the internet. And actually it blocks the smooth muscle cells. So coming to the point, and it's working on that. Similarly, we got pimocrolimus, same way it works like that. Now this drug actually was used by the dermatologist for eczema, and it has been picked up from there and being used as a vascular smooth muscle inhibitor in the preclinical stage. So now there are another drugs which are coming up called as huminerolimus and the tiolimus. They are all very potent drugs with the limited side effects, and still being studied in the literature, and a lot of trials are being done with these drugs. So a lot of money has actually been put in into these technologies. I don't think the amount of money you see from the internet which has been put in all these technologies is not going to go away, because I think people have got to spend a lot of money into this. They work or not, we will see. Now this is another very important drug, a DO drug. Means 1:9 ratio of paclitaxel and sirolimus. And it's been, this actually has been used now. It encapsulated in the biodegradable nanoparticles, prolonged drug distributions, lesser cytotoxic effects of the paclitaxel, and good points about the sirolimus combined together. So this balloon is being experimented and being studied. So combination of both the drugs. Then come the gene-based therapies which are being included, that you actually have the microRNAs attached to the technology, and it actually gets into the vessel wall and modify the vascular healing. So of course there are limitations because of regulatory complexities and delivery challenges, and still into the preclinical stage. Now there are a lot of combination therapies which are being used now. So I'm going to go about that. Now one stent is being developed in India actually. It's been heparin and sirolimus combination. So it's been in the coronaries, not in the peripheries. It's been experimented and the trials are going on. Then there is another compound called the genestin and sirolimus combinations is being experimented on the stents and being studied. Now this is a very interesting technology, EPC, which I was talking about. So what do is you take a stainless steel or cobalt chromium stent, you put in a CD4 antibodies on the top of that, and you place the stent inside the vessel. So CD4 antibodies actually will capture the endothelial progenitor cells from the circulation, and actually all these cells will encourage rapid endothelialization, what we want, so that you don't get an earlier stent thrombosis, and they will not actually initiate vascular smooth muscle proliferation. So this is also being studied in the world, and a lot of studies are being going on. Then there is another stent with an anti-VGF drug from UK, which there actually it decreases the formation of new vasovascerums and actually cause plaque stability. So it works on a different mechanism. So this is also another way to look at into it, so that you don't have a huge problem with the neointimal hyperplasia. So we know about the PLLA stents, which we talked about, is being coated with various drugs now and being studied. And there is another one which is very important, is Riva stent. It's a tyrosine-derived polycarbonate. It's radio opaque. You know, what happens is the biodegradable stents, most of these stents, you cannot see them. And they are radiolucent. So you just have to have, depended on the markers at the ends, to deploy it. So sometimes their deployment becomes a difficulty. Then there is a magnesium-based stents which are being studied now. Bare stents were not very different from the normal bare stents, but now they are being combined with the drugs like the sirolimus and everolimus. So much is there. Every company and every country, I think, is trying to prove that this toy is better than the other. And I think it was going to happen the same way. There no comparison of the toys will happen, and everybody will be confused at the end which one to use, and everybody will be using it according to the availability and the cost. So what are the limitations? So biological challenges is a very important, because the drug elution kinetics or calcified lesions, smaller vessels, how are we going to do it? Then there is the clinical evidence. There is not lack of large scale, there is a lack of large scale randomized control trial. We saw in 1.5 days, 150, 100 patients, 80 patients, you know. And that's why we are all confused at the end of 1.5 days. Should we use it or should we don't use it? Unanticipated side effects, which we don't know. Extensive testing and approvals is a huge amount of money you have to put in. Regulatory hurdles are there. And cost of the balloons in our country especially. Technological barriers, which I have talked about, is a very big problem, especially like a sirolimus. And there is a market resistance, because the drugs, the companies who have already invested so much money on sirolimus and paclitaxel, and you saw Australia still using paclitaxel coated balloons everywhere. So I think it's so complicated, and it's not only the studies. I think it's a lot of money driven, market driven, company driven, a lot of physician driven, a lot of other factors also comes into the picture before we understand everything. So the newer agent, in summary, this is the last slide sort of, in developments are like a biolimus, which is there already, is being used in many countries. Jatrolimus is also being started using in many countries now, and it is a rapid metabolism antiproliferative. Novolimus and sirolimus derivatives and gene-based therapies and the combinations, they are all into the experimental and the preclinical stage. And maybe in the next 1, 2, 3 years, we will hear about them as we go along. So in conclusion, I will say newer agents holds promises for improved efficacy and safety. And overcoming all these parameters is very critical, and multidisciplinary collaborations and advanced trials. And I think physician-led trials are more important, especially, you know, what Shekhar had put in yesterday, Basel III trial. I think this is a very important trial, because what you see, all company-driven trials shows benefits, all physician-driven trials shows no benefits. So it's a very, very, very important, statement. And I think we need more trials which are physician-run, not company-driven, and to know does they work or not. Thank you.
Thank you, sir. Any questions?
पूछो मत यार प्लीज, मेरे को आता भी नहीं है ज़्यादा इसमें.
Sir, thank you very much. We'll move on to the next talk. I would invite the chairpersons, Dr. Shabnam Fatima, Dr. Vivek Singh, and Dr. Pranay Pawar to kindly come in front. And Dr. Preeti Sharma will be speaking on planning a national registry on drug elution, the roadmap.
Apologies for my bad voice. I'm sorry, it must be sounding very aghast. I would thank Rahul sir because he made a platform for my presentation. The reason, all the more important reason, is because we cannot conduct RCTs, so we need to have registries in which data will be entered, hopefully unbiased, because the registries will be run by physicians because we will be taking data. So that is very important, that why should we have a national registry, not only for any of specific to drug elution, but also for all patients who are having any issues in peripheral vascular disease. The main problem what we face when we start a registry is, even we do a robust planning, but taking that registry to the end, what is a bigger challenge for us. Planning is very proper. The mishaps happen during the execution, and bigger mishaps happen during interpreting what the information from that registry is. So I would start off by talking on what actually the word registry, it is a Latin word which was initially used in the royal regal areas, in which it used to say that whatever a person has, it has to be listed, recorded, and it goes back to the king. Now, if we use it for R, is whatever is happening, the king is the patient. So whatever information is happening, it should be for the benefit of the patient. So talking about the drug elution registry, it would be a real world practice to know whatever we are using is safe, has effectiveness, and at the same time, if there are some adverse events which are happening when we are using these devices, it is easily picked up. So why do we need this kind of national registry? Is because in this 1.5 day, we have seen how the treatment for these vessels have evolved. Initially, we were doing POBA, then we were doing stent, then we were putting DCBs, DABs. Now morning, Venkat sir also showed scaffold. So it is a technology which is in evolution. So we need to know whatever is happening or whatever is coming up with the trials which are being done in the process of evolution. Is it safe for the patients? At the end of the day, we are physicians, and for us, patient safety should be the prime importance. And if we have a registry, it will be an unbiased data which is collected from the patients by the researchers or clinician, that will help us to know the long-term outcomes related to that data, whatever drug eluting system is used. Especially, like, what I feel is we are relying on all the trials or whatever has been done in European population. So we don't have data. Maybe our pattern of disease is definitely different from what we see in European patients. So if we have our own registry, we can come out with our own guidelines, and we can say that, oh, this is what evidence says from our registry, so we will follow these guidelines. So once we have this, we will have improved treatment. It obviously, there will be cost effectiveness, knowledge sharing, and as we all know, now Google Doctor, all our patients are reading what is available. So if we have a registry, we will have our guidelines, and we can effectively show patients, okay, if you use this for this kind of lesion, this is the success rate, this is the failure rate. So we should have a registry which will say in black and white, this is what will happen, and we don't know whether you will land in 70% success rate or 30% failure rate. And at the end, we can also have a global standard so that we can also show the healthcare practices at international level. So this is the reason why we need it. So how are we going to plan it? So first is we should know what is the main purpose of doing the registry. The main purpose is to do patient safety and treatment efficacy. This second part is very important. We need to know who all should get involved or engaged in this. Healthcare providers, regulatory agencies, patient advocacy groups, and to some extent pharmaco companies also. Because to run a registry there is a lot of funding which is required, and as physicians we might not be able to do it on our own. So it is always better to get other pharmacological companies also involved. Now data point and data standards. We should come to a consensus what data should be included in the registry, the kind of technology, the user access, and obviously legal and ethical consents, informed consent from the patient. We don't have HIPAA, which is very active in US, but at some point of time we will also have to know the patient privacy regulations. And to implement, we can start doing a pilot project, see how it is there to test the registry, train all the users so that there is smooth operation, monitor and evaluate whatever the effectiveness and data quality is. After the data is collected, analyze it and report it so that it can come out as a publication and as a guideline at national level. Okay, when we are using DCBs or DCS, what is our success rates, and explore opportunities for collaborating with other healthcare organizations. Now these are very few challenges which came to my mind. Is the stakeholder engagement. Who will enter the data? I have a patient. I feel the patient needs a DCS, DCB, but in my busy schedule I might not be able to enter that data. So that is why we will have to have an organization with whom we can collaborate, and that person would be assigned, okay, it will be a centralized system. Whoever is using that kind of DCB will enter. Now, at the same time, we have to make sure that it is user friendly. If we give 20-30 questions, I'm sure most of us will not be able to enter it, or it won't be very interesting. So it should be something which is not very exhaustive and easily manageable. Patient confidentiality must be the prime importance, and at times there is inconsistent funding and policy support because of a lack of support from government or institutional bodies. So these are the challenges which we can have when we are planning for a national registry. So I wanted to travel from my home in Borivali to IMA Hall. So that's why I used Google Map, because so we need a road map. The first step of the roadmap is like-minded people like us who are thinking about using drug elution should come together. Get all institutions which are doing this kind of work to get actively involved. Also get involvement of our national societies like VSI. There is a very good registry which is run by National Health Authority by Government of India. So we get them involved, make it a user-friendly digital data, and once there is data, then we can use AI to interpret that data and come out with guidelines. Thank you.
That was an excellent talk, ma'am, and actually you've hit the nail on the head with this one. There are no VSI office members here, so I would just like to state a few points. So we at CMC run a big surgery hub with the UK. We do about 40 articles a year, and we have about 8 to 10 studies which run. The annual amount which we spend on that research hub is about 5 CR a year. So that's the amount you're looking if you want to do any good research. We have about 800 hospitals, I think, associated with us. So you need to have a good research team, because I can't enter my information, you can't enter your information, because it'll be the wrong information entered. Nobody likes to write about what operations have gone wrong. We only like to enter what operations have gone well. We get people who say that, I operate everything and it does well. Unfortunately, that's not the case. A lot of operations fail. You fail half the time you succeed. So unless the VSI, unfortunately or fortunately, has to spend a significant amount of money if we are serious to get a registry done. The number two, the ICMR right now is very active in looking for research grants. And they're only handing it if you have at least 5 other KIM hospitals associated with you. With the, it's a mix of, MBBS institutions or state institutions and all. So I think if the VSI should look to sort of, involve 10 to 15 hospitals and then apply to the ICMR for a
Even DST has come up with lot
grant.
of this.
Like right now, we wrote a very simple, study on how to avoid surgical site infections, and very simple, just 4 things. And we said we'll go to so 100 hospitals. We got around 4 CR, so from ICMR. So it's easily accessible, very easily accessible. But you have to do the work. Once you have it, once you have to go to 100 hospitals, then you need a full team to do it. You can't be going to 100 hospitals, or I can't be going to 100 hospitals. So that the VSI really needs to look at, get a research team, hire research associates. They're expensive. They cost around, every research associate, you have to pay around 1.5 lakhs a month, plus you have to pay his fees of going all over India and doing all that work. So it's about 1 to 1.5 CR if you're looking to start it at all. Otherwise, this will, so we'll again speak about all this, so next time also.
I think it's a very, very important what you presented. I think very valid points. And I just add to his points, because if we involve the pharma companies to pay for the grants, and then, something like Cerdia.
Yeah.
So when they do the studies, they actually don't interfere.
Yes.
What are the results which comes up? So either the companies who are involved, we have a written agreement before that they will not interfere. What are the results? So it's a sponsored but not interfered.
Yes.
This is one.
Yes.
Second is, I feel somebody has to be the lead. So like you are presenting, and if you want to take a lead in this, because somebody has to be the leader who is active. And I know you are very pushy and active. So yeah, there has to be somebody who has to take, because I have experience, we did a venous ulcer registry. Really, I'm telling you, all my colleagues, it's a nightmare. Nightmare means nightmare. And either they are busy schedule, and also, to be sorry, in India, most of the physicians are not interested in research. And because it's a true thing. And very true, people don't bother to, mere ko kya milega isse? So what we did, there was no collection of data from 10 centers for 7 months, except 2 people. And because I was a leader, I have to enter the data. Okay? But it was a nightmare, and nobody is entering. So then I put in 1,000 rupees for 1 patient. Then 7 more doctors started entering the data. So there was a finances attached to entering the data. So, and I'm paying 1,000 rupees. What I did, I just hired a girl for 4 months on 15,000 rupees, a secretary. And I trained her for 4 hours. Because it's not very difficult. And I told my MO that once she enters the data, you just check it up for 1 hour. And I paid the MO 500 rupees per patient, 500 to the secretary. So whatever came from the company, I just distributed among themselves. But what other doctors are doing is, other centers, they kept all that money in their own pocket, and they didn't hire anybody with the money which we were giving. No, this is a true fact I'm telling. And that's the problem, because you need to include the centers or the people who are interested. There will not be more than 30, 40 centers who will be using these technologies routinely in a clinical practice. So involve those centers. Fourth is an ethical approval. Now, we cannot do this study without an ethical approval. And all institutions nowadays, they charge because now they have come to know that there is a lot of money we can make from this. Data. And institution like ethical approval. So it was free before,
Now they charge like 50,000. Some institutions got like 2 lakh rupees.
50,000 is for our hospital also we are giving.
You know, and 50,000 rupees for ethical approval. Yeah, like, you know, so they have to think about this fees also, you know, which is a problem, the funding which is there. I personally feel VSI can do this study very easily. And how, in a simplified, this I learned from my mistakes which I did. We hire one research fellow. And no, urgency is very expensive, just my thinking. And you know, we hired it later, we threw them out after 2 months because they were not doing much. And so we hire one girl or boy who is trained in collecting the data. There will not be huge amount of drug-eluting stents which will be put in across the country. And let's say maybe 1 or 2 cases a day.
Yes.
And we teach her these 20 simple points needs to be copied. And the physician can click the photographs of the data and send it to her. She enters the data, and your responsibility will be, like whoever the team in charge is to collaborate that whatever the data is entered is okay.
Yes.
And you know, 7 to 8 cases a week, which is huge, I feel. And if we run it for a year, because it will be the cheapest way to do it, because you can hire a girl for 25,000 rupees nowadays, research fellows.
Yes.
I have got a research fellow with me, and she's like 18,000 rupees.
Yeah, we also have.
So something like that. And we collect the data at the cheapest cost. Then we hire a statistician, and actually I can collaborate this study with PGI because the epidemiological head is a very close friend. And they actually, to have their name inside, and Ajay will be there anyway from PGI involved. So to have the study will be statistically free. They write the paper free of cost. So, you know.
So let's start. I'll form a WhatsApp group on the National Registry for Drug Elution.
And ISMR
we'll
project also is very good idea. We should apply for
So,
it.
Preeti, you know, it would be worthwhile finding out also why many of the registries have failed. What were the reasons? I will tell you, when I was in Belfast, the consultant with whom I was working, Barris Dissa, he wanted to start a NIVASC registry, Northern Ireland Vascular Registry, and I'm talking in 95 or something like that. There was a great resistance from many of the people, right? And again, feeding, why should I feed my data into it, those kind of things. But over a period of time, it almost, I don't know, maybe required more than 5 years to streamline the whole process, and then everybody started feeding the thing. So,
Dinesh,
what are
totally
the
agree with that.
reasons
Yeah.
some of the registries fail?
Yeah. So
Is we
what
need to address those.
Including centers, not because of the name, but because of we know the background of every doctor in the country. You know, it's a small community. And we know who has got the research mind, who does not have. And you know, just not include the name into the paper, but people who are going to put in, because you have to put in some time in putting the data.
Yeah, we are just short of time. Thank you, Dr. Preeti. We'll go to the last talk of the day and the symposium. Dr. Paresh Pai sir will speak on thrombosis and anticoagulation after drug elution.
त्याच्यामध्ये कॉपी केलं होतं जरा प्रॉब्लेम आहे मग काय देऊ दुसरं परत पेन ड्राईव्ह द्या ना मला can't, I need the slides.
Charge.
Talk like Steve Jobs on the ramp, sir, with a mic.
एप्पल खाना पड़ेगा. Vessomag चखा लिया. Vessomag drug elution. त्यावर इकडे क्लिक करा. नाही तिकडे नाही, तिकडे त्याच्या खाली. Hi everyone. Sorry, we'll try to keep it short. I know everybody is tired. अभी कम किए हैं. So okay. So drug elution, you've heard almost 1.5 days. So this is basically done, used to prevent and treat arterial restenosis. And we've seen that two drugs or two group of drugs, one is your rapamycin, sirolimus and paclitaxel, and you've all gone through this. There's just one, last two lines are the important ones which I felt, which have not been covered. So the anti-proliferative effect is more on the hypoxic atherosclerotic cell, which is more seen with sirolimus rather than with paclitaxel. And that's one of the reasons why sometimes you are seeing that the sirolimus is giving better responses. Another important thing is drug-eluting stents with sirolimus continue to be used, but with paclitaxel have not been used because of safety concerns. Now what happens with this is that here you can see a picture of how the drug, once you put it inside the body with the balloon or the stent, there's dissolution, then there's absorption, and you can see that the active drug starts getting into the walls of the artery, and the distribution varies, whether it is sirolimus or whether it is paclitaxel. So what is important is how does this work? So it's inhibition of new intimal formation, but the side effect is that it also inhibits re-endothelialization, as we talked about, inhibition of EPC, homing and proliferation, and induction of tumor factor, tissue factor, which causes thrombosis. So risk of thrombosis starts with immediate use, so it's early. It can be late, it can be even very late. So there are people who have stopped using anticoagulation, adequate anticoagulation for say 1 year, and they have ended up with thrombosis, mainly because of these reasons. So what are the factors which promote thrombosis? So it's delayed re-endothelialization and healing of intima. So this causes exposure of intimal defects post-angioplasty. It causes exposure of the stent, and more important, the polymer to the blood flow. Tissue factor expression, that's inhibition of mTOR and activation of JNK. This is a picture which shows paclitaxel stimulates JNK, which is important because that stimulates tissue factor, and rapamycin inhibits mTOR, which is important for inhibition of tissue factor. But because that gets suppressed, what happens is the surface tissue factors get exposed and the clot formation is there. So procedure related factors, high pressure barotoma, so we discussed that yesterday. that using low pressure sustained is giving better results than using high pressure. Improper apposition of stent to the arterial wall, that is also important. Many a times we find that we don't have the stent we want and we use whatever is available, and that itself can create more problems. So availability becomes an issue, may not be so much in big centers, but in smaller centers where there is an issue of availability, that becomes an issue. Hypersensitivity reaction to polymers used to hold and deliver the drug. Inadequate anticoagulation. So this could be because of resistance to antiplatelet drugs, especially the CYP2 C19 allele, which is very important for resistance for clopidogrel. Delayed starting or premature discontinuation of anticoagulation and antiplatelets. This itself can cause issue. And then we have this thing whether we use a dual platelet inhibition or use a double antiplatelet therapy. And there are patient-related factors which include low ejection fraction, diabetes, advancing age, and thrombotic occlusions. So when you have occlusions which are thrombotic and we use this technology, the thrombus there itself can cause stimulation and further thrombosis. So this is a picture, I'll show you a couple of these, primary to push home the factor that here you can see that there are two issues here. One is the platelet factor, which is important, and the stimulation of the intrinsic and extrinsic pathway. Similarly here, if you see the platelet, there are three issues that take place. One is adhesion of the platelets, second is activation of the platelets, and third is aggregation of platelets. Right? So in addition of platelets, you have aspirin, which is an important part, which is a COX-1 inhibitor, which blocks the thromboxane inhibitor, and as a result of that, it reduces the adhesion. Also, it reduces the activation of the platelets. So here, PAR1 antagonists like rivaroxaban is an important factor. You have the ADP-P2Y12 receptor antagonists, which includes your clopidogrel, prasugrel, ticagrelol, ticlopidine. You also have the 5-HT2A antagonist, which is naftidofural. So this is used, there were studies for using prevention of restenosis and improving claudication. And you have the aggregation inhibitors, which is the GP1A2A inhibitors or GP2B2A inhibitors like your apixaban and monoclonal antibodies. So this is gives you a more detailed, easily readable format, which tells you the thromboxane inhibitors is the aspirin, the PAS inhibitors is the Vorapaxar, rivaroxaban, the ADP receptor antagonists, which includes the clopidogrel, the prasugrel, the ticagrelol, the ticlopidine, and the G2P3A inhibitors, which is the apixaban. Okay, so this looks a little complicated slide, but it's important for two reasons. One is it also tells you what is the role, besides antiplatelet, what is the role or involvement of the antithrombin. So we all know about the aspirin and the COX-1 inhibitor. We know about the P2Y12. Dipyrimidol. Everybody remembers this drug? Persantin. This was also used and very popular at some. So there are lots of drugs which we are not using, which may have a role, especially if you have a situation where the existing drugs are not working. Silistazole. Silistazole is a phosphodiesterase 3 inhibitor, and that also has an antiplatelet factor. You have the PARS inhibitors, which is the rivaroxaban and the voraxafor. And don't forget the apixaban. And last but not the least is the thrombin inhibitor. So whether it's unfractionated heparin, low molecular weight heparin, whether it's dabigatran. So if you look at this, this gives you an idea of comparison of various antiplatelet drugs that are available for us. One is aspirin, acetyl salicylic acid, COX-1 inhibitor to thromboxane X2. It plays an important role for prevention of adhesion, activation, aggregation, as well as thrombus, because it acts at the fibrin level and stimulates or rather blocks the formation of thrombus. Clopidogrel, which is a thienopyridine, So it's a P2Y12 ADP inhibitor, and it's mainly involved in prevention of activation and aggregation. Prasugrel is a thiopyridine prodrug, and that also acts at activation or aggregation. Ticlopidine, nobody uses it now primarily because of the risk of agranulocytosis. Ticagrelol, which is a cyclopentyl triazolopyrimidine, again that's an ADP inhibitor, and that also acts similar to your clopidogrel, prasugrel. Silestazole mainly acts at prevention of aggregation, which is a PDE3 phosphodiesterase 3 inhibitor, and rivaroxaban, which is a monocarboxylic acid amide, which blocks the PARS4 and PARS1 inhibitor and prevents activation as well as prevents thrombus formation. So what is the evidence for antiplatelet post-revascularization? Not necessarily related to drug-eluting, but any procedure that we do. So PAD antithrombotic practice patterns vary widely. DAPT after endovascular intervention is the norm, but one is not really sure how effective it is, but that is standard practice. And there is a lot of reluctance to move away from the standard practice. Little data to support varying DAPT prescribing patterns, which are generally influenced by coronary artery disease treatment patterns. There is no positive data published in the PAD revascularization setting since antithrombotic trialist collaboration in 1994. That's almost 30 years ago. So what are the DAPT recommendations after PAD interventions? So you have different bodies. You have the ACC AHA guideline, which says that DAPT may be reasonable to reduce the risk of limb-related events after lower extremity revascularization. You have the ESC, which is DAPT is recommended for 1 month after intervention. CHEST gives a guideline which says single antiplatelet, recommend against DAPT. Zilver PTX, they use DAPT only for 2 months. Impact SFA, DAPT for 1 month without stent, 3 months with stent. Now coronaries they use for a longer period. So therefore these kind of guidelines can create more problems for us, and as a result of that we have to really think about whether we can follow it. So despite lack of robust evidence, patients are often treated with DAPT following peripheral revascularization. And here you can see that you have patients with only with an oral anticoagulant, no P2Y2 inhibitor, P2Y inhibitor before or after procedure, P2Y2L inhibitor less than 30 days after procedure, more than 30 days after procedure. So what is also important here to understand that there is what is the incidence of clopidogrel resistance. It can be 8 to 44%, but that's pretty high. So that means if you are going to be relying on aspirin and clopidogrel, and especially using a drug-eluting some technology, one doesn't really know whether your anticoagulation or antiplatelet is going to be effective or not. And that's a big ask after you have done all this procedure. Prasugrel resistance is less than 11.5%, so less than 10%. Ticagrelol resistance is very rare, and that's one of the reasons why the cardiologists tend to use either Brilinta or Prasugrel when they are doing all these procedures, and most of the times they are using drug-eluting stents. So let's look at this slide again, which I had showed first. So is there any combination that works at both levels? So what are the two levels? So one is the platelet level, and second is the thrombin level. So if you have something which acts at both levels, then it will be beneficial for our patients. So what is this combination? We all know this slide, especially this came up when we were talking about the COMPASS and the Voyager study. And here you can see that your aspirin, low dose aspirin, acts at the COX-1 inhibitor level, and the rivaroxaban low dose again acts at two levels, the platelet level as well as the fibrin level. And that's how you can see to it that you get better protection. So DPI is dual pathway inhibition, and that's supposed to be work. So what are the protocols that are used? So one option is you use, this is mainly for coronaries. Sorry, this is for so we'll compare with both ischemic heart disease as well as PAD. So DAPT of aspirin with clopidogrel. So generally the cardiologists tend to preload before they are doing any of these procedures. so that you have that protection. Primarily because they are using, most of them are only using drug-eluting stents. So preloading is an important part, and generally most of them will continue ISD for a longer period, dual platelets. Post-op, in PAD, we usually started post-op, and we can give it for 3 to 6 months. Some people discontinue the second antiplatelet much earlier and then stick to only antiplatelet. Prasugrel and ticagrelor is used extensively by the cardiologists, but we don't have any data of using it for peripheral arterial disease. DPI, again there is a reluctance from the cardiology side to use these molecules. Whereas because of Voyager, we find that these are patients who have already been on DPI, or you start them post-operatively as early as you can. And generally the idea is to continue for lifelong. What about 3 drugs, aspirin, clopidogrel and rivaroxaban? Again, you don't have any cardiology data for that. Many times what we are doing is vascular surgeons tend to use this post-operatively. At least start rivaroxaban maybe a few days later when they feel that it is safe. So what about when you are using it for DCB or DES? So again, same thing. We are not really sure what the data is, but what we can use is decide is based on what we have seen. So what about role of clopidogrel as a third agent post revascularization? The efficacy and safety of rivaroxaban plus aspirin versus aspirin alone is consistent regardless of background clopidogrel. So here you can see that the primary outcomes, efficacy outcomes are good. Safety outcomes are also good. Patients more likely to receive clopidogrel in the Voyager study were the Caucasians, ladies, hypertensives, diabetics, hyperlipidemia, CAD with prior intervention or CABG, prior peripheral intervention. All these patients were already on clopidogrel, and therefore there was a reluctance to stop it. Addition of clopidogrel as a third agent is associated with a higher rate of bleeding during exposure, especially if it is used for more than 30 days. In the absence of a clear benefit, clopidogrel exposure along with aspirin and rivaroxaban should be minimized or avoided to reduce this risk. So, the subgroup analysis of the clopidogrel in the Voyager study, the objective was to determine if efficacy and safety of rivaroxaban were consistent regardless of background of clopidogrel use, and to explore the temporal patterns of bleeding in relation to exposure and duration of clopidogrel. So here you can see the clopidogrel use at randomization, 50%, aspirin again, so it was well matched, no difference in p-value. You can see that there is difference in the duration of use. Most of them were used for 30 days or so. Median duration for drug-coated products which was given is for at least 31%. Here you can see aspirin was 32. So again, not statistically significant. So really speaking, we don't really have an answer. But what you can see here, that when you have clopidogrel added up, the risk of bleeding starts going up after 30 days. And that's one of the reasons why you try to reduce your triple dose to less than 30 days if possible. So unfortunately, there is no real data, and one really wonders what should be done. So you follow the cardiology protocol, or we follow scientific rationale where there is some scientific basis based on which we can use, play safe and continue the same, or develop our own evidence, and which is where the registry will make a big difference and decide what you want to do. So all of you must have seen the slide before. It's my favorite slide. It's always important to aim high but play safe. Thank you.
We put in these two drugs, because we don't have any day-to-day test to seek aspirin resistance patients, clopidogrel resistance patients. So I actually use any intervention I do. I put in aspirin, clopidogrel, and rivaroxaban, and on the first day, and it starts. And after 4 to 6 weeks, when I feel that epithelialization happens, no data of course, epithelialization happens, so I stop depending upon the risk factors, one of the antiplatelets. And I think the reason why I use it, because I don't know which patient is going to have an aspirin resistance, which patient is going to have a clopidogrel resistance. So I'm just using anti-2 platelets and praying that at least one drug will work as an antiplatelet. But that's a practical thing, because how will you find the resistance?
So I was trying to do a search to find out what is the risk or what is the incidence of aspirin resistance. And surprisingly, you found 60 to 70? Much less, much less. What is problem is that intolerance to aspirin is more common. That is so when you say resistance, it is resistance to use because of risk of bleeding. Not so much that action of this. And these are all small doses. So another way of looking at it is that, okay, you can do, so simplest way of understanding whether how aspirin is effective or not is doing a bleeding time. And bleeding time can be a guide to tell you what's the issue with that. Sorry?
It can.
Supposed to.
Paresh, question is, any interaction with warfarin, paclitaxel, sirolimus?
So the point is that warfarin is a double-edged sword, and especially for two reasons. One, you are never sure whether you are going to get adequate anticoagulation or not. And the second important thing is the risk of bleeding if it becomes excessively anticoagulated becomes a major issue. And that is one of the reasons why, because the safety profile is so small, so narrow, that is the reason why, there is a bit of reluctance to use
Anything in literature which would say
literature, no.
that warfarin is contraindicated
No,
if you use paclitaxel?
I haven't, frankly speaking, I have not checked that out, but that is something which may be worth considering. But coming back to Rahul, what you said, that 4 to 6 weeks, you expect the endothelialization to take place, and then you could think of, instead of giving triple dose, you make it DPI. The point is, if it is DES or DCB use, then we can expect that endothelialization is not going to take place in 6 weeks. So those are those situations where this becomes very important, primarily because you are using it in smaller vessels, the flow is slow, the disease is very bad, and therefore we need to really think, how do we play safe?
Sir,
You will prefer rivaroxaban with aspirin or ecospirin and prasugrel or
So generally, problem is that prasugrel use or ticagrelol use in peripheral arterial disease is not seen so often. So that is the reason why we don't have data. But we have data when you are looking at DPI. So Voyager gives you that information which nobody else is giving. And that is the biggest challenge, to use something which, okay, it works in coronaries. We don't know what the effect is in peripheral arterial disease. So here you have something which is tried and tested, where you have data. So why not then stick to that?
Sir, since we in the
cardiology practices, they realized there is a lot of clopidogrel resistance, so they switched over to Brilinta.
Precisely.
But Brilinta also has its own set of complications and adverse effects. So I was in Brilinta for a while, and I used to have this air hunger kind of thing. And cardiologist said, stop immediately. That's the commonest thing. Brilinta.
That's ticagrelol. Yeah.
Ticagrelol, are we in the near future, are we expecting that we should switch over from clopid in lieu of clopid, because in view of the high resistance to clopid?
So frankly,
promising results are shown as far as the cardiologists are doing it in our center as well.
Okay. So another option is stick to prasugrel rather than going to clopidogrel, because that's similar thing. It's a prodrug. It is more effective. The absorption is faster. The effect is longer. So that way, your chances of getting resistance is much less.
Okay, so that was an excellent talk. And
Thank you. कल रात को पूरा हिला दिया सबको. जरा एक कार्ड नो. Excuse me. एक कार्ड on ध्यान.
We all invite Dr. Raghuram Shekhar sir for the vote of thanks.
Yes, so quick vote of thanks. Thanks all of you for coming and making this a very, very interactive thing. The whole purpose of this meeting was to have more of discussion and less of just hardcore topics. I think most of the topics, despite all the time constraints and the people having to leave early, I think we've had a fairly good interactive session. There are lots of take-homes, even for me. I mean, it was a learning even for me. The lot of things which I didn't know, which I came to know from you. I'm sure most of you would have, if we can, I think, take home at least 20% of what was actually put forward, I think the purpose would be served. This is the first of, this kind where we thought that a single theme focused meeting probably is more in tune with our type of practice rather than have a huge conference of 4 days where we can, threadbare. So I'd like to thank all the participants, all the faculty, all of you have, really raised the bar of discussions, and thank you for coming and have a safe journey back. Yeah, thank you also the industry and Mr. Shivanand and his team. I think they put forward a kind of a seamless, the whole organization was so good. Most of us in the organizing committee, doctors are busy with their practice or something. They took a lot of load off our shoulders and they've done an excellent job. Thank you very much, Shivanand and your team. I think in future Vessomag events, we don't need to look further than Shivanand, I think. Thank you very much. Thank you the industry. I think they have been amazing in their support, with this kind of logistic support as well as financial support which they gave us. Thank you very much.
Would request everyone to collect their certificates from outside. They have been given. Thank you.